usual activity on Friday of each month. SHRC Pune, that is State Health System Resource Center Pune, which is a wing of NHM, mainly devoted for the research, resources, and capacity building for the NHM and the entire State Department of Maharashtra. From the month of November 2022, we are conducting the clinical webinar on every third Friday of each month. The date may vary, but every third Friday is a common part. Till now, we have conducted nearly 11 webinars, and these are our what we call as a 12th webinar. We are completing 1 month, 1 year today. Till now, we have conducted the webinar on measles, malaria, and dengue research methodology in research work, COVID-19 updates, post-mortem and medical issues for the medical officers, commonly occurring issues for the medical officers. Then the critical care service management and the updates about the ICU. Then comes the need of the palliative care and orientation of the national program of healthcare for elderly. Then in the month of May, we have conducted the webinar on the heat-related illnesses, that is HRI, and the management of the heat stroke and management. For this lecture, in the month of May, we had our distinguished dignitary from the Meteorology Department of India. We are conducting this webinar with the people devoted in that subject, the resource persons which are well known to that subject, to improve the knowledge and updates of the medical officers, those who are serving in the rural area and the remote area. Then in month of June, we have conducted the clinical webinar on the National Tuberculosis Elimination Program, right from the program and field activity, how it works, and what are the recent updates and the various drugs we are using now. In the month of July, we had the epidemiology and clinical management of the waterborne disease, because you know the July, August months are full of a rainy season, so the waterborne diseases get escalated. So we have conducted epidemiology and clinical management of the waterborne disease. And in this month, fortunately or unfortunately, we are conducting the second session. One emergency session we have taken because there are certain spike of the dengue cases after the rainy season, especially in the Palghar area, Mumbai area, and the east north part of the Maharashtra. So our commissioners are requested to have the brief of the dengue fever. So we have conducted the webinar on the management of the dengue fever on the 11th of this month. And this is now the routine webinar of our every third Friday series. Today webinar is on the snake bites and the practical case studies of the snake bite management. This webinar, fortunately, we are having the support of the Path Foundation. Dr. Sushil is there, and all dignitaries of the Path foundations are here, and they are arranged the resource persons. The resource persons are very dignified persons. One from the Chhattisgarh, who is sitting besides me, and none other than Padma Shri Dr. Himmatrao Bhaviskar, who has devoted his life for the snake bite and scorpion bite management. So in this way, we are proceeding forward for the clinical webinar series. SHRC Pune is also conducting the administrative webinar along with this clinical webinar on every third Tuesday and Wednesday of each month. Till now, we have conducted the 2 sessions on the administrative, because as we know, we are having much clinical knowledge, but we are lacking the administrative knowledge. For our medical officers, those who are serving in different capacities, maybe the drug dispersing officer, may not be drug dispersing officer, maybe head of the institutions, they require all the administrative knowledge, establishment knowledge, pension rules, finance rules, all these things. So we have started conducting the administrative webinar from the last month, that is from the July 2023. Till now, we have conducted the 2 series, and in the month of September, we will again have one lecture with the 2 topics on the administrative side. All these activity, once you register on the ECO platform, you will able to know all the activities, all the dates, the topic of the subject, those who are the resource persons and the material required for the subject, or any question answer asked, any material asked for that, this is also uploaded on the eco platform sites. So this is a comprehensive site which not only conduct the webinar but give the input and also the output in the form of the material or documents required in the future. You have to register only once and you are getting the access of the web platform, that is the eco platform, for the administrative webinar, clinical webinar, or related policy matter, documents, research papers, and all these things. Even the government GR also. So just I will stop over here. I will not waste much of the time because our distinguished speaker is sitting beside me. Yeah. So with the help of the Eco Foundation, we are starting this webinar today, that is on the epidemiology of snake bites and practical case studies of the snake bite management. Just remember, these are practical case studies of the snake bites. These are the actual experiences in the field, not only the theoretical pattern. Today we have two distinguished speakers for us, resource persons. One is Dr. Yogeshwar Kalkonde and another is none other than the Padma Shri Dr. Himatra Bhaviskar. So we will start this activity. I will introduce our first speaker, that is Dr. Yogeshwar Kalkonde. He has done his MBBS from IGMC Nagpur and his MD Medicine from the GMC Nagpur itself. Then he had the Masters in Clinical Investigation, MSc, University of Texas, and at San Antonio, and MD in the Neurology, which is equivalent to our DM Neurology in India, from the Palace College of Medicine, Austin, Texas. He has huge experience. Just I was talking with him before starting this webinar. So he has done his MD Medicine, then he shifted to the Neurology, then he again come back to the Public Health Department just for our sake, because he feels the Public Health Department is very, very interesting and unending challenges and tasks ahead. So he joined the Public Health Department not as a government officer capacity, but working in the public health cases and studies from last 10 years in the Gadchiroli in Maharashtra and Chhattisgarh also. His topic today is the epidemiology of the snake bite, commonly found poisonous snakes and transmission of the bites, asserting the innovation, diagnosis and testing, basic management principles, guidelines for snakebite management at the different levels of the health system, and prevention and the first aid. These are the topics he will cover today. Before that, I am handing over mic to Dr. Kalkonde sir. I would just like to remind you that the pre-test has been published on the chat box. Kindly fill the papers, the questions they are given. Nearly 10 questions are there. So we will evaluate during this webinar, and then we will have the post-test at the end of the webinar. So I request Dr. Yogeshwar Kalkonde sir to address our medical officers. Thank you, sir.
Thank you. मी थोडी सुरुवात मराठीत करतो आणि मग आपण इंग्लिशला स्विच होऊ. सगळ्यांना फार प्रेमाने नमस्कार. तुम्ही सगळे ग्रासरूट्स तळागाळात काम करत आहात आणि तिथलं आरोग्य सुधारायचा प्रयत्न करत आहात. माझी स्वतः 12 वर्ष मी ग्रामीण आणि आदिवासी भागामध्ये काम करतोय. तुमच्या कामाविषयी मला फार आदर आहे आणि त्या आदरातूनच मी हे आज सेशन घेतोय. सेशन घेतोय आपण ते स्नेक बाईट वर घेतोय. ग्रामीण भागात जे काम करतात ते सगळ्यांना माहिती आहे की सर्पदंश हा खूप मोठा प्रॉब्लेम आहे आणि त्याच्यापेक्षा कधी थोडासा मोठा असा प्रॉब्लेम आहे की बरेच वेळेला जे मेडिकल ऑफिसर्स असतात त्यांना थोडीशी ट्रेनिंगची कमी असते किंवा थोडीशी साशंकता असते स्नेक बाईट्स मॅनेज करायला. तर आपण आज प्रयत्न असा करू की याची जी थेरोटिकल बॅकग्राऊंड आहे, स्नेक बाईट्सवर पुस्तकं वाचायला गेले तर खूप किंवा आर्टिकल्स खूप मोठे मोठे आहेत. आपण पुढच्या 1 तासात अगदी संक्षिप्त रूपामध्ये स्नेक बाईट मॅनेजमेंटची थेअरी पाहू आणि त्याच्यानंतर हिमंतराव भावस्कर सर हे प्रॅक्टिकल केसेस घेतील. तर पहिला अर्धा भाग हा थेअरीवर राहील आणि पुढचा अर्धा भाग प्रॅक्टिकलवर राहील. तर असं मिळून आम्ही दोघं मिळून हे दोन्ही कव्हर करू. आणि हे तर खरं मला फार आनंदाची संधी आहे की महाराष्ट्रातल्या दूरदूरच्या मेडिकल ऑफिसर्सशी मला बोलायला मिळतं इथून आणि हिमंतराव भावस्करांसारख्या मोठ्या माणसासोबत पण मला बोलायला मिळत आहे. तर विल नाव स्टार्ट मॅनेजमेंट ऑफ स्नेक बाईट्स. कॅन वी गेट दिस इन PowerPoint फॉर्म? Presentation form.
Presentation form. Full screen. Full screen. Full screen.
सगळ्यांना प्रेझेंटेशन दिसत आहे, स्लाइड्स दिसत आहेत. दिसत आहे. चालेल, आपण अशाच याच फॉर्मॅटमध्ये ठेवूया सध्या. तर मी खालील मुद्द्यांवर बोलेल. सो फर्स्ट विल स्टार्ट विथ एपिडेमियोलॉजी, देन व्हाट आर द कॉमनली फाउंड पॉइजनस स्नेक्स इन rural areas of central India, symptoms of snake bite, then management of snake bite, management of anaphylaxis due to anti-snake venom, complications, course of recovery, transport of patient, and prevention. So we'll cover each of these topics in short, but important necessary information would be there. So on an average in India, there are more than 10 lakh bites per year, or 1 million bites per year. This is a large number. And out of that, close to 60% occur in males and close to 40% occur in females. But the good thing is around 70% of these bites are without signs of toxicity, most largely unpoisonous, non-poisonous snakes. But the number of deaths in India is quite large, 60,000 deaths per year. And most of these deaths occur in the productive age group of 30 to 69. I mean, all of you work in rural areas, adults have to go work in the field, and that's where, usually snake bites occur. And only 25% are under the age of 15 years. Usual time where maximum snake bites occur is between June to September, and we are in that season right now. And most of the snake bites occur outdoors. The case fatality in India, meaning that out of 100 snake patients with poisonous snake bites, how many will die, is around 4%. Next slide. And please feel free to interrupt and ask questions if you have any. So with that, we'll just take a whole sort of a look at India's map and see what are the areas where there is high risk of snake bites. So if you look at maps of Maharashtra, there are regions bordering Gujarat, regions bordering Madhya Pradesh, where Satpura ranges are there. And then if you come to east, it's districts of Gadchiroli and Chandrapur. I worked in Gadchiroli for 10 years. So these are areas where there is very high risk of snake bites, and also in Konkan region where you have a lot of snake bite risk. Next, please. So let's look at the simple statistics of snake bite. How does it work? And if you go to rural area, people will first take the patient with snake bite to a local Vaidu or Pujari. And I'll tell you why Pujaris are very successful. Because if you look at all 100 snake bites, out of that 70 are by non-poisonous snakes, or where there is no poison injected. Then 30% are only because of poisonous snakes. And out of these 30%, close to 50% are dry bite. Dry bite meaning that the snake bites but doesn't release toxin. So only remaining 50% where are the cases where poison is released. So if you look at out of 100, only 15 persons will have serious envenomation. And out of that, a significant number could be mild envenomation, and the rest would be moderate to severe envenomation. So any person, if you look at the statistics, the success rate of any Vaidu would be about 85%, because only in 15% cases they are going to have snake envenomation. And that's the reason why people prefer to go to Vaidus, because experientially they feel that a lot of patients are getting better with care from Vaidu. Next. So what are the poisonous snakes in India? The big four poisonous snakes in India are Russell's viper, saw-scaled viper, krait, and cobra. And a lot of you might have seen these snakes when you work in the rural area, but let's take a look at their pictures. Next, please. So this is Russell's viper, large snake, and you can see chain-like markings. The way you recognize this is by chain-like markings. Next. These are some more pictures. I mean, there are region-to-region variations as to how snakes look. So next is saw-scaled viper, where the beads are not that marked. And you can see that this is saw-scaled viper. Next. Krait, you can see a black dark snake with white markings, and there is something called as banded krait. These are extremely poisonous, and we don't have any antidote against these, but these are very quiet snakes. They usually don't sort of, very rare. The banded krait bites are quite rare. Next. Again, this is one more picture of common krait. Next. And cobra, we have seen, all of us have seen cobra somewhere, either in movies or through Garudis that used to visit us. So these are the four big snakes that are, poisonous, and we need to know a little about them. And this is the structure of fangs and the venom gland. So what happens is through the fangs are large teeth, and these are hollow teeth through which venom is delivered. And there is a venom gland. And what snakes can do is when they sort of bite, they may or may not release venom. Usually releasing venom when there is no prey is not beneficial for the snake. So that's the reason some of these bites are just dry bites. And the bites by snakes that are young in age, they cannot control the venom release. So oftentimes the baby snakes end up, poisonous baby snakes end up releasing more venom than the adults. Next. So let's look at what are the commonest causes of poisonous snake bites in India. So if you look at these statistics, close to 45% bites are because of Russell's viper. So, but again, there are regional variations. So there will be some areas where krait is more common than Russell's viper. But if you look at pan-India picture, and these are data based on 33 studies from 2000 to 2019, close to 45% bites are because of Russell's viper, followed by krait, followed by cobra. And then there are other varieties. And in these studies, up to 20% of snake bite, the snake was unknown. Next, please. So what are the symptoms after snake bite, both poisonous or non-poisonous? The first reaction would be that of anxiety. So anyone would feel anxious if we have a snake bite. So symptoms would be anxiety, tachycardia, palpitations, malaise, and paresthesias. But the symptoms which are suggestive of systemic envenomation is by poisonous snake is abdominal pain. Patient complains of abdominal pain. You have to be careful that this could be a poisonous snake bite. Vomiting is again a sign of poisonous snake envenomation and the venom getting into systemic circulation. So vomiting, unless it is induced by herbal products, so oftentimes in rural areas, the patient is first taken to a Vaidu and they give some products to eat, and that can induce vomiting itself. So if you take history and if you're sure that they didn't receive any of these, and patient is having vomiting, then you have to be prepared to give ASV. Next. So what are the clinical syndromes? There are three broad clinical syndromes due to poisonous snake bite. So let's take a look at them. Next. So this first clinical syndrome is that of painful progressive swelling, meaning that after snake bite, at the site of bite, you will have progressive swelling and also along with that pain. The second syndrome is vascular toxicity, where there is problems with the blood vessels or there is bleeding. And the third major clinical syndrome is neuroparalysis. So let's take a look at them one by one. Next, please. So painful progressive swelling, this is due to local venom toxicity seen in case of Russell's viper, saw-scaled viper, and cobra bites. What happens after these bites is limb is swollen, skin gradually gets taut. As the limb gets more and more swelling, the skin becomes tight and shiny, and then there would be tender lymph nodes. So if there's a bite on foot, then if you palpate groin lymph nodes, and if they are tender, then that's an indication that patient might have systemic envenomation, and it's why poisonous snake. Next. And usually swelling will extend higher from limbs and sometimes to trunk. I had a patient who actually had a bite on foot, and then he had swelling all the way up to his neck. So the swelling can really extend too much, to the extent that one starts worrying whether this patient has any cardiotoxicity, because of which the patient is having swelling. Then if the swelling is too tight, it causes compartment syndrome, where there could be loss of pulses, very tight skin, and limb cannot be compressed. So if you press on the skin becomes so tight that you cannot press it. Next. So these are some pictures of painful progressive swelling. You can see fang marks being marked, and you can see swelling on the foot. Next. Then vascular toxicity, where you see local swelling as well as blisters and ecchymosis. This is commonly seen with Russell's viper. Next. So these are pictures of vascular toxicity. You can see blisters large, and you can see the necrosis of skin. Next. Again, you can see local toxicity with sloughing. And the systemic signs of this syndrome would be bleeding from gums, nose, hematemesis, hemoptysis, ecchymotic patches on the body, and sometimes gastrointestinal or retroperitoneal bleeding, where patient will present with severe abdominal pain. Next. These are pictures of bleeding from gums. You can see subconjunctival bleeding, and again bleeding on the extremity as well as ecchymotic patches in case of Russell's viper bites. Next. Then what are the systemic complications? So there could be intravascular hemolysis leading to brown colored urine or hemoglobinuria. There could be acute kidney injury, which is because of the toxin, and this leads to decreased urine output. Because of vascular toxicity, there could be bleeding in brain. So coagulopathy can lead to bleeding in brain. Patient can be, get unconscious or can have seizures. There would be vasodilatation, cardiotoxicity, and capillary leak leading to hypotension. Next. Then the third syndrome is that of neuroparalysis, seen most commonly with krait, followed by cobra, and rarely viper bites. As I said, there is variation in toxicity of these four major snakes across regions. So
You will find certain certain regions. So when I was practicing in Gadchiroli, there are certain regions in Chhattisgarh where viper bite will produce mild neurotoxicity. Otherwise, it's not very common with viper bites. The commonest cause of neuroparalysis is crate, and in crate bite, the neuroparalysis starts typically 6 to 30 hours after a bite, and the 30 hours is something that one needs to remember, because if the patient comes in, then the neurotoxicity can start as late as 30 hours. So where you could discharge the patient because there is no envenomation and patient might come back because of neuroparalysis. Cobra bites, it occurs early from 30 minutes to 6 hours. Next. So in neuroparalysis, what will be the symptoms? So we have to remember 2 P's and 5 D's. So 2 P's, ptosis, there will be drooping of eyelids, there will be paralysis, and this is typically a descending neuroparalysis. And the patient will develop diplopia initially, followed by dysarthria, followed by dysphonia. So dysphonia meaning the patient will not be able to speak, and dysphonia then soon progresses to dyspnea, where patient will have difficulty breathing, followed by dysphagia. They will not be able to swallow. And as I said, as against Guillain-Barré syndrome, where this is ascending neuroparalysis, in case of snake bites, it is descending neuroparalysis. Next. And these are examples of ptosis. Normally, the upper eyelid should cover about 2 millimeters of the cornea. And if it is more than 2 millimeters, then you have to suspect ptosis. For sure, it should never, the eyelids, upper eyelids should never touch pupils. And if you find that upper eyelids are touching pupils, that means the patient has neuroparalysis. And to compensate for this ptosis, the patient also has frowning on forehead. So these forehead muscles are trying to pull the eyelids up. So frowning is also a sign that patient is going to have is having worsening ptosis. Next. So how do we evaluate a patient? So let's start. Next. So key question before you evaluate a patient, the patient would be brought in as a case of some unknown bite sometimes. I mean, many times patient may not know that there was a snake bite. They will go for out there defecation, and patient is brought in that he was sitting in bushes and suddenly he felt that something bit him or her, and the patient will be brought in. So big question for you, if the patient is brought in very early, is whether this, what kind of bite is this? Is this snake bite? And then the next question is, does the patient have signs and symptoms of envenomation or toxicity? And then third key question is, how stable is the patient? Are there any complications? Does the patient need immediate referral? Next. So what we do is you ask certain questions, you assess or evaluate the patient, you analyze the information based on your history and examination, and then you prepare a treatment plan, and then you treat. Next. So what do we ask? So first and foremost is make sure you are speaking kindly with the patient. The patient is extremely stressed. You can imagine yourself in the position of the patient. If we have snake bite, we also are going to be very scared. So key thing is reassurance. And if you have ASV, just tell the patient that you have anti-snake venom, and you need not worry. And if needed, you will start anti-snake venom. And then start interrogating, was the patient really bitten by a snake? So for example, I had a patient where the patient trying to put his hand into a crevice on the wall, and then he felt that something bit him. So we're not sure. He did not see whether it was really there. And then there was no bite mark. So as I said, as we come, we'll talk about it. Crates sometimes do not leave bite marks. So you have to worry whether this is a crate bite. But then you push the patient and ask, did you really see the snake or not? And sometimes patients say that, no, I was just scared whether there might be something bit me and maybe that was snake. That's what I thought. So you have to really try and interrogate and see whether the bite was really by a snake. Again, what the patient was doing when he was being bitten by a snake. If the patient was in farm and then because of the snake bite, the patient got scared and started running towards home, then that tells you that because of increased physical activity, the chances of systemic envenomation go up. So if the patient is running, his arm is not or limb is not immobilized, and instead because of fear he runs, then the toxin will quickly come from that limb into blood. So that is something that will tell you that the patient could have early signs of envenomation, systemic envenomation. Next. And then we had to assess really whether time from since bite, so duration of bite and presentation, location of bite. If the bite is closer to heart, so for example, I had a patient young child who was bitten on earlobes. It's closer to heart, so you expect that the signs of envenomation might develop early. How the patient was transported, I already alluded to it. If the patient was walked with limb was immobilized, then the chances of systemic envenomation are less. But if the patient ran or the extremity was not immobilized, then the chances of systemic toxicity are higher. Next. And then, especially with viper bites, you have to watch for kidney injuries. So you have to ask what was the last time patient passed urine. In many cultures they don't give water to the patient, and so oftentimes patient is brought dehydrated up to 12 hours or 20 hours, where patient has not consumed anything because of local perceptions. Then you have to ask whether there was any blood in vomiting. The patient had vomiting, whether there was any blood in vomiting or sputum, whether the patient has any breathing or speaking difficulty, and any other medical illness. So someone who has diabetes or hypertension or heart disease, you have to be careful of that as well. I mean, such a patient gets snake bite, the chances that the bite and the anxiety because of it can precipitate acute cardiac event. Next. Then we, assessment always start with the vitals. So look, you look at you do your ABCs, make sure the airway is unprotected. If the airway is unprotected, look if how is the breathing or respiratory rate. If the breathing is shallow, look at the circulation, look at arterial pulses, look at blood pressure and oxygen saturation. Next. This we already talked. Blood pressure is important because in viper toxicity, you can have hypotension. Or if the patient is dehydrated, then patient can be little hypotensive. Next. And then local assessment. You quickly look if there are any fang marks. And then, as I alluded earlier, sometimes crate bite may not have any fang mark, and sometimes non-poisonous snakes might show some fang marks. So these are examples. Usually, you would see 2 puncture wounds because of the teeth, which are longer. These venom delivering teeth or fangs are longer than the rest of the teeth. Next. And again, so then we have to do clinical assessment. So again, for these 3 syndromes, we'll do clinical assessment. Next. So look at local swelling and mark the extent of the swelling. So if the patient has had, bite on toes and the swelling is up to ankle, you can mark when you first see the patient that the swelling is up to ankle. And then in next 30 minutes or so, if the swelling increases from ankle to mid leg, then it tells you that it's the swelling is spreading rapidly, and that's an indication for starting anti-snake venom. Next. Look for signs of continuous bleeding from the bite site. If if the snake bite is 1 hour before, normally the blood should clot. But if from the bite side you see that blood is oozing, then that means that blood is not clotting, and that again indicates bleeding disorder, which is commonly seen in case of Russell's viper. Look for oral bleeding. Look for subconjunctival bleeding. Next. And then neuroparalysis, again, as I said, typically patient presents with ptosis or dysarthria, and the patient may not be able to lift the head from pillow. So if the patient is unable to lift the head from pillow, that's an indication that the patient needs intubation. That's called broken neck sign. So these are simple signs. You just ask the patient to lift the head from pillow, and if the patient has a lot of difficulty, then patient is likely to, so patient has definitely signs of neuroparalysis, and patient is likely to need intubation. The second simple test you could do is single breath count. So ask the patient to count from 1 to 40 in a single breath, and if he or she cannot go past 30, then that tells you that the patient has impending neuroparalysis. The patient needs to be quickly started on anti-snake venom and needs to be transported. Sometimes patients are, especially in rural and tribal area, they are not able to count until 30. So ask them to just hold their breath for 45 seconds. So the way you do it is ask the patient to hold the breath, and you start your counter on the mobile phone. And if a patient cannot hold breath more than 45 seconds, then the patient is having impending neuroparalysis. And the last is if the patient cannot complete 1 sentence due to breathlessness. So that's, again, these are very simple things that you can do at bedside, which will tell you that the patient is going to need intubation and anti-snake venom before that. So what are the tests that are needed? We only need one important test, which can be done even at the PSC level, and that test is called 20 minutes whole blood clotting time. So those who are working at the PSC, make sure your lab technicians know this. It's a very simple test. I'm going to explain in a while. The other test, if you have them available, is urine albumin or detecting blood in urine using simple dipsticks to look for proteinuria and hemoglobinuria, which indicates renal involvement. And again, that will tell you that the patient has signs of systemic envenomation. Next. So this is how the simple 20-minute whole blood clotting test need to be done. So all you need is a very clean and dry glass tube or a bottle, which is not washed before. If the bottle or the tube has been washed before with detergent, that interferes with this test. So make sure that the bottle or the tube is not washed with detergents or soap, and it's a clean new tube. And what you need to do is just collect 2 to 3 ml of whole fresh venous blood and put it in that tube and start timer. And after 20 minutes, you have to go and tilt the tube and see if the blood clots. Normally, if the blood should clot, If the blood is not clotting, as is seen here in the picture, that even after tilting the tube after 20 minutes, you can see the blood is flowing along the lateral wall of the bottle. That means that the blood is not clotting, and that means that whole blood clotting test is positive, meaning that patient has signs of envenomation and there is coagulopathy that is developing. So you have to start the patient of anti-snake venom. And make sure you don't shake or intermittently do not check or move that bottle. So 20 minutes the bottle or the tube needs to stay still. So again, as I said, this is very simple test, can be done at the PSC level. All you need is a clean bottle or a clean tube, which is not washed with detergent. Next. So what do we do? So for example, if the 20-minute whole blood clotting time, if the blood doesn't clot, meaning that the patient has coagulopathy, you start anti-snake venom and you recheck after 6 hours until the blood starts clotting. If the blood clots, but you're still suspicious that the patient has potential viper envenomation, then you can check hourly for the next 3 hours, and then every 6 hours for 24 hours. Next. And what are the other tests? If you're at a CSC or district hospital, you could do blood urea, serum creatinine to look for signs of toxicity. You could do CBCs where you would see increased hemoglobin, leukocytosis, or decreased platelets. ECG to look for any cardiotoxicity. You can check electrolytes and CPK. But as I said, primary care, these are not needed. And all you need is this simple 20-minute whole blood clotting time. And just if you have anti-snake venom in that test, you can reasonably manage many patients with snake bite very safely. Next. And then based on your clinical examination history, you then analyze, then you make a judgment whether is this a snake bite. So for example, if there's a patient who came with unknown bite and you evaluate and there is no swelling and whole blood clotting time is negative, then you are not sure what kind of bite is this. So you need to observe this patient for signs of envenomation. And if there are signs of envenomation, then you look for, if the patient has neuroparalysis, then your clinical diagnosis is this is most likely crate bite followed by viper bite. And then the key question is the patient hemodynamically stable? If the blood pressure is okay, SpO2 is okay, that is something that you need to take a decision. Next. So then when do we start anti-snake venom? So if any one of these or more are present, these are the indications of anti-snake venom. So first thing is local swelling involving more than half of the bitten limb within 48 hours of the bite, right? So if you, as I said, that if the patient comes to you with a bite on toes, on feet, and then within half an hour, you see the swelling has extended up to half of the leg, then that clearly tells you that this is an indication for starting ASV. A rapid extension of swelling beyond wrist or ankle within few hours of bite on hand or foot. That's another indication where you would start anti-snake venom. Spontaneous bleeding from gums, nose, or subconjunctival bleeding. Coagulopathy, if you have 20 whole blood clotting time positive or INR is more than 1.2, you need to start anti-snake venom. Next. Neurotoxicity, which we talked about, bilateral ptosis, external ophthalmoplegia, meaning that patient cannot move his eyeballs, or paralysis, where he or she is unable to lift head off the bed, or they are unable to complete single breath test count. Then cardiovascular abnormalities like hypotension or shock is an indication that there is systemic envenomation and the patient would need to be put on ASV after getting the blood pressure up, either by giving normal saline or by giving dopamine drip. Acute kidney injury. So if the patient has oliguria, so I had a patient who presented with history of snake bite 12 hours ago. When he came, he had swelling on the limbs and he had not passed any urine for the last 12 hours. So that's again indicates that there is local toxicity, most likely Russell's viper, because kidney involvement is common in Russell's viper. Then hemoglobinuria or myoglobinuria, the patient will complain that the patient is passing red colored urine or brown colored urine. That's again an indication that the patient is having hemolysis and at risk of kidney injury, and that's an indication of anti-snake venom. Next. If the patient has no signs of envenomation, then do not give ASV, because ASV is an expensive resource, it's a rare resource, it's not easily available. And if you give ASV just because there is pressure from the family or you feel stressed without there being any signs of envenomation, that's not the right indication for giving ASV, because if you give, sometimes if unfortunately develop second time the patient has been bitten by a snake, you give ASV, there will be severe reaction. So if there are no signs of toxicity, you clearly tell the patient that patient might be bitten by a poisonous snake, but we'll have to observe for signs of envenomation. And as soon as signs of envenomation develop, you will start them on anti-snake venom. Until then, you just put them on normal saline. So start a drip and get the drip going so that the patients and family members are slightly comforted that there is some treatment that has started. Next. So what happens is if there is signs of toxicity, your job is clear cut that you have to start anti-snake venom. But if there is no signs of toxicity, then it becomes little, you have to be much more careful and keep monitoring patient very closely. So you have to monitor patient every 1 hour for if there is increase in swelling, then you have to check for 20 whole blood clotting time. You have to look for signs of neuroparalysis like ptosis, breath holding, or single breath count, or broken neck sign. And you have to keep the patient under observation for at least 24 hours. So if you are working in a rural area, patient comes in with unknown bite, then you have to keep the patient under observation for 24 hours. Next. And so the treatment is, as we discussed, is anti-snake venom. It's polyvalent anti-snake venom that we have in Maharashtra as well as in other parts of India, meaning that it neutralizes the venom of all big 4 snakes. So Russell's viper, saw-scaled viper, krait, and cobra, right? So you don't have to. There are other treatments where there is, snake specific treatments or antibodies which are available. But for that, you really need to know which snake was responsible for bite. But for us, we don't have to do that because we have a polyvalent ASV, and it is available either in the powder form or a liquid form. So usually, most of the times, we now have powder form, which is lyophilized form of the anti-snake venom. And since it is powder form, it is much more stable at room temperatures. And then before giving it, you have to reconstitute it. And there's a quiz that I'm going to ask you, and maybe you can answer in the end. So how anti-snake venom is prepared? So I'll be coming to this at the end. So, but this is a quiz for you. So at the end, I'll ask this question: that how anti-snake venom is prepared and why it is important to know how it is prepared. Next. So the way we reconstitute anti-snake venom is it is in powder form. We add 10 ml of distilled water and shake gently. It's protein. Any protein, if you shake, then it there is a lot of frothing, and we don't want frothing. Venom has to be only given by IV route. Do not give anti-snake venom by intramuscular route because there is poor bioavailability. In older days, we used to inject anti-snake venom locally where there was bite, or maybe spray it on the bite site. That is no longer recommended, right? So the only way you have to give anti-snake venom is you have to give it IV. Next. And there's one thing that I want you all to remember. If there's one just one take home that you take from today's session, that will be this: that the first complete dose of ASV is 10 vials. Right, so you would have seen practices where you give 2 vials and wait for if things get better, then give another 3 vials. Do not give that. The WHO strongly recommends against this, because what will happen is sometimes the toxicity then becomes too much, which is not controlled by 2 vials of anti-snake venom, and the patient will have to unnecessarily lose his or her life. So make sure that once you have determined that this is poisonous snake bite based on the signs and symptoms and lab tests that we have discussed, just give 10 vials of anti-snake venom, right? Are you able to hear me? I'm sorry, there was some disruption in the link. Can you please let me know whether we are audible?
Eco Nagpur.
Okay, great. Thank you. So again, as I said, I'm going to repeat this again, that once you decide that this is poisonous snake, the dose is 10 vials, nothing less, right? Next, please. So what is the function of ASV? So ASV is going to neutralize unbound venom injected by the venomous snake. The venom that is already bound is going to have its toxic effect. But what is still unbound is what we neutralize with anti-snake venom. So once whatever the damage is done will not be reversed, but there will be circulating venom which is not bound to the receptor that it usually binds to, and that would be neutralized by the anti-snake venom. And the other thing you have to remember is that among children, the snake doesn't differentiate between adult and child. So it will not say, oh, this is a child, I'll just release a little bit of venom. So always remember that the amount of anti-snake venom given is standard 10 vials. And I'll just describe you one case where there was this new medical officer at one of the PSCs in Chhattisgarh, and there was a child who came with snake bite, and he started 10 vials, and the nurse there, loudly said in front of relatives that, sir, ye to bachcha hai, isko pura kaise denge? And the medical officer was junior, so he lost his confidence that in front of everyone, if the nurse is saying so, how would I do? But what he was doing was right. He was giving the complete dose. So the logic of that is the snake doesn't differentiate between the child and adults. The snake has no way of knowing whether you're a child or an adult. So dose of ASV is same is in children as that of adults. Next. So again, as I said, the typical dose that is needed for effective management of snake bite is anywhere from 10 to 25 vials. And I'll come to that. The rule is how to give anti-snake venom is 10-10-5, and I'll come to that in a short while. But if you give more than 25 vials, it's usually not very useful. And on the contrary, it will start creating more systemic toxicity. Next. So what you need to do if you're working at the PSC level, this is something that you need to have as a snake bite kit in the PSC or CSC. Wherever you see emergency patient in the season of monsoon, make sure before June, like late June, you should have this kit available with you, because then you can find everything at one place. Otherwise, it gets chaotic and you start anti-snake venom and suddenly patient develop reaction, and then you are looking, shouting, where is adrenaline? And the nurse is looking for adrenaline. So to avoid that, just keep these simple things with you at the PSC or CSC. So 10 vials of ASV with distilled water or water for injection, 2 ampoules of adrenaline, 2 ampoules of hydrocortisone, 2 ampoules of Avil or chlorpheniramine maleate, 2 ampoules of atropine, and 2 ampoules of neostigmine. So this should be your kit. In addition, next, you should have well-functioning ambu bag. Right. So as soon as June comes, you have to, if you in your region you see snake bites, make sure your ambu bag is functioning. Face mask that fit the ambu bag of various sizes. So you can keep one child size and one adult size to make sure if you are unable to intubate the patient, tubes. The endotracheal tubes that you need is 8 for adult males, 7 for adult females, and for children the usual formula is age divided by 4 plus 1. So the question is ASV bolus or dilute in NS. The ASV always has to be diluted in NS, 500 ml NS.
I am audible to everybody because somebody complained there is no sound.
Why is disrupted? There's some issue with signal.
Yeah.
Okay, audible. Fine. All right. So there was one question in the chat box, and please feel free to type your questions in the chat box, and even at the end we'll have a session. So whether the ASV has to be given, IV push should not be given. All your ASV should be added to 500 ml of normal saline. We are coming to that. The next slide or the slide next to it is that. So if you push IV, if you give direct push, the patient is higher likelihood of patient having anaphylaxis, because you are putting in foreign protein inside the body at a very high speed. Right. Next. So we'll come to starting ASV. So apply BP cup to patient's arm and monitor blood pressure, because if you start ASV, sometimes the patient's blood pressure drops. So in that case, you have to stop ASV for some time. So keep patient propped up in bed if BP is normal, or flat in case or head low position if BP is on lower side. So you would see this in case of viper bite. Sometimes the patient presents in hypotension. So there the patient has to be tilted with head low position, and then you start first normal saline bolus, and then you start ASV once the BP is little up. And the physician should be at the bedside or easily available when the anti-snake venom is going. Next. Before starting anti-snake venom, draw adrenaline in a syringe and keep it by the bedside. And this is needed. I'll come to that why we do this. And also keep hydrocortisone and Avil injections ready. Dissolve ASV powder, each vial in 10 ml of distilled water, and remove 100 ml from normal saline or DNS, 2 of the fluids you could use, and remove 100 ml from it and add 100 ml of ASV that you have reconstituted in that bottle. Please do not shake, because then it causes frothing. Next. So before starting anti-snake venom, you need to give 0.25 ml of 0.1% adrenaline subcutaneous, right? This is a recent recommendation, because in one study in Sri Lanka, there was reduced risk of anaphylaxis by 40%. So before starting ASV, just give subcutaneous 0.25 ml adrenaline on abdomen, and then you start ASV. You have to be careful if the patient is under 15 or over 60 years of age, because adrenaline will cause slightly increase in heart rate. Then initially start anti-snake venom initially slowly. You want to give anti-snake venom in 1 hour, right? So you have to keep that in mind, but starts initially slow. If you use adult drips, the usual drip rate is about 6 drops per minute. This is very high flow rate because you have to give 500 ml in 1 hour, right? And then monitor BP at least every 5 minutes for first 30 minutes, then every 15 minutes for 2 hours. If you have your nurses trained and if you have this protocol by side where you typically handle your emergency patients, it would be easy for everyone. And we have to give 100 ml of ASV. That means 10 vials of ASV over 1 hour period, right? So this is how we have to do it. Take out normal saline, 100 ml, and then put 100 ml of ASV in that. Gently shake and then start the drip. And then after the ASV is done, maintain a slow drip for 24 hours. You may need to give ASV again, and we'll come to that next. And after starting ASV, monitor vitals. Mainly, you look at blood pressure, pulse rate, and SpO2 every 1 hour. Monitor urine output strictly. And if you are suspecting Russell's viper bite, where a patient comes with a lot of swelling on leg, then insert Foley's catheter to monitor for urine output. And you have to look for something called as oliguria, which is less than 400 ml of urine in 24 hours. Or if you're by bedside, you can you expect that there should be at least 20 ml of urine per hour, right? Next. So while giving ASV, we need to remember what ASV cannot do. So ASV cannot reverse necrotic action of the venom on tissue, right? So if the necrosis has already started, it will take its own course. It will not be reversed. It will not immediately reverse local swelling. The local swelling takes about 15 days to go away in Russell's vipers. And you have to counsel relatives about this, because they believe that if the swelling has not disappeared, the toxicity is not gone. And especially in rural area of Gadchiroli, they always thought that there are embedded snake teeth inside the tissue. So they would ask, sir, aapne tumhi bagitlaय का तिथे दात फसलेला असेल दात. So that is something that you have to counsel patients on. And then it will not reverse renal failure once it has started. It will reverse coagulopathy because the reversal is done by liver. So what it does is, when you give anti-snake venin, it will go and bind to unbound toxin, and whatever the clotting factors are destroyed will now be regenerated by the liver, because liver is normal. Liver doesn't have any issues if the blood pressure is normal. Next. Then you have to watch for anaphylaxis while giving anti-snake venom. So what are the signs and symptoms of anaphylaxis? Like any anaphylaxis reaction. So you will have, patient will describe itching. The patient will describe urticaria, which are red rashes. Patient might complain dry cough, nausea, vomiting, abdominal pain. They might have diarrhea, tachycardia, fever, hypotension, bronchospasm, or angioedema. Next. Or there sometimes with ASV, I'll come to that. There's a question how to give ASV in small child. So here, what you will do is, here you will keep the amount of 100 ml of ASV, but reduce the amount of the fluid that you are giving. So for example, the child is very small, then you don't want to give overload child with 500 ml of fluid. So what you do is, you take 100 ml of ASV and add another 100, keep 100 ml of for normal saline or fluid in the bottle, and just give that. One other reaction that you would see with anti-snake venin is pyrogenic reaction, where patient will have chills and rigors and fever and sometimes hypotension as well. Next. So how do we manage these reactions? There's one thing before we go to management of reaction is the skin test of ASV is not recommended. So these are old practices. When I was in medical school, we used to do this, but this is no longer recommended. So if you're doing this, please stop this practice. Next. So coming to managing anaphylaxis, next. So first and foremost, if the patient has signs of anaphylaxis, stop ASV, then give adrenaline. Here you have to give adrenaline intramuscular, and the amount would be twice the amount that you initially gave, right? So the amount of adrenaline would be 0.5 ml intramuscular, and in children you have to give 0.01 milligram per kilo in deltoid or thigh, and you wait for 5 minutes where anaphylaxis, see if anaphylaxis is improving. One of the things that many of us, remember, first treatment of anaphylaxis is hydrocortisone. That is not the case anymore. First treatment of anaphylaxis is always adrenaline, right? So please remember this. Don't give hydrocortisone first. Give adrenaline first, and wait for 5 minutes. If no response, you can repeat the dose of adrenaline, right? And then if there is no response, then you give IV hydrocortisone and chlorpheniramine, because if you see, anaphylaxis occurs because there is sudden hypotension, and if you give hydrocortisone or chlorpheniramine maleate, it acts more proximally. The deleterious effects of adrenaline are on vasodilation and sudden shock that is occurring, which is immediately countered by adrenaline, but will not be easily countered by hydrocortisone and chlorpheniramine maleate, right? There is one question in chat box. As you told, watch for signs and symptoms to develop, then start ASV. till poison will get bound, and bound poison will not neutralize by ASV. So what we need to do? That's a good question. So you have to at least have one sign of toxicity, because without that you cannot determine whether you could have dry bite. So where you will see fang marks and there is no swelling and nothing happens afterwards, and patient is all right. If you have if you have a patient who came with swelling on foot which is rapidly increasing, then you immediately start anticyclin and it will do its job, right? So if you see any toxicity which I mentioned in the indications for ASV, if you start ASV at that time, then you're fairly going to manage and snake bite well. Next. And if the patient develops fevers, then stop ASV, do body cooling with sponging. You can give oral or injectable paracetamol if you have injectable. If there is vasodilatation, BP is dropping, you can give IV fluids like normal saline. Next. So how do we monitor and give additional doses of ASV in case of coagulopathy or neuroparalysis? Next. So, for example, there is a patient who came in with bite on foot with swelling, and when the patient came to you, the swelling was up to mid leg. So it was above ankles and up to mid leg. And then you give, then you check for whole blood clotting time. It was positive, meaning that blood did not clot. So you give 10 vials of ASV, and then you wait for 6 hours. After 6 hours, you again check if the patient has clotting or not by doing this 20 minutes whole blood clotting time. If the patient's blood doesn't clot after 6 hours, you give another 10 vials of ASV and then recheck after another 6 hours. If the blood is still not clotted, you give 5 vials of ASV. So the rule I mentioned, 10, 10, 5, is how you give. And even after that, it is not clotting. If additionally giving ASV is not going to help much. Coagulopathy can self-correct. And if after 6 hours, if the whole blood clotting time is negative, then no ASV is needed in that patient. So 10 vials was enough. Next. Persistent swelling in viper bites need no more ASV than after clotting defect is cured. So in viper bites, you will have local swelling as well as coagulopathy. So once you have reverse coagulopathy, there is no need to give additional ASV, because the swelling initially will increase and then gradually go down. Any use of FFP in coagulopathy? Yes, if the coagulopathy is really bad and if the patient is at a higher center, FFP could be considered. A good question. The neuroparalysis. Next. Again, what you give if the patient has ptosis or other paralysis which is not needing intubation. So patient just present with ptosis, you ask single breath count, and the single breath count is 40. So you are assured that the patient doesn't have impending respiratory paralysis. Then you give 10 vials of ASV, and you can wait for 1 hour and see if the neuroparalysis has improved. If not, then you can give another 10 vials and then start making preparation of referring patient to a higher center, because if the patient needs intubation, he needs to be in a center where intubation is possible, right? And again, as I said, even after giving 10 vials, it is possible that the neuroparalysis progresses because the venom is already bound to the receptor. So in that case, you give 10 vials and ship the patient as early as possible to a higher center. Next. So what are the indications for intubation or mechanical ventilation? Intubate immediately if the patient has imminent respiratory arrest. So for example, patient is in respiratory arrest, is gasping, if the breathing is absent or very inadequate. If you see that secretions are pulling in pharynx with loss of gag or cough reflex, so patient is unable to talk and there is a lot of drooling from mouth. If the oxygen saturation is less than 90% despite high flow oxygen, the patient is going to need intubation. If the patient is altered, unconscious and not able to breathe well, then you have to intubate. If there is upper airway obstruction with stridor, then again you have to immediately intubate the patient. You have to prepare for intubation, meaning that there is impending respiratory failure when the single breath count is less than 30. So if it is just 10 or 15, then anyway you are going to immediately intubate, because these criteria on the left will be operational. If the patient cannot complete one sentence in a single breath, again you have to give this. If the breath holding is less than 45 seconds, you have to give this. If neck muscle weakness is there, again you have to give this. There's another question, good question, how to give atropine and neostigmine. Thank you, sir. I'm coming to that. Next slide is that. Next. So there's one thing before that slide comes. So can a patient need intubation despite giving ASV? The answer to that is yes, because the patient, whatever ASV you are giving is to neutralize unbound toxin. If the toxin is already bound, despite giving ASV, the patient will go into neuroparalysis. Next. Right. So again, transporting patient with respiratory paralysis. If the patient comes to PSC and you start patient on ASV but feel that patient is going into respiratory failure, then you have to transport patient. And what can you do at a PSC? If you know how to intubate, attach AMBU bag to it and ship the patient. If you cannot intubate, just get a good, nicely fitting mask, attach the AMBU bag to it, and ask the relatives to bag the patient until the patient is transported to a CSC. Next. Then coming to atropine neostigmine, that was the question asked. So patient with cobra and viper bites with neuroparalysis sometimes respond to atropine and neostigmine. Patient with crate bite may not respond. We can leave this. So the way so what you do is do not give atropine neostigmine if the patient has completely recovered from neuroparalysis. Patient shows side effect in the form of fasciculations or bradycardia, or if there is no improvement after 3 doses. Next. So how to give atropine and neostigmine? So give atropine first, then give neostigmine, because neostigmine will cause a lot of pooling of saliva in the mouth and patient will feel uncomfortable. So you have to give atropine first, 0.6 milligram in adults, either IV or IM, followed by neostigmine, 1.5 milligram. Right. So this is the regimen. Wait for 30 to 60 minutes, see if the patient improves. If patient has incompletely improved, give another trial of atropine neostigmine. And if doesn't, then you can give a third trial. But if after third trial there is no response, stop it. It is better to give anti-snake venin than atropine neostigmine because if it is crate bite, it is unlikely to respond to atropine or neostigmine. There is a question: if there is only swelling but 20-minute whole blood clotting time is negative, what is the initial dose of ASV? It's again 10 vials. So with swelling, if you are convinced that this is toxicity, then this is progressive painful swelling is the syndrome that you have diagnosed. Give 10 vials. Do not, there is this tendency on Indian part because of scarcity that, why use so much, just give 2 vials. That is no longer recommended, right? I used to do this. So I'm also a culprit of, doing this practice, because in those days, we used to do this. Right now, this is not recommended. So once you decide if the patient has any of these 3 syndromes, you give a full dose of ASV, right? Next. Right, then you have to watch for other complications. So acute kidney injury seen with Russell's viper bite. Again, if the patient is having oliguria, you have to monitor for oliguria. If the patient has not passed urine for 12 hours, give a fluid challenge of 500 to 1 liter normal saline, right? And you have to do not give more than this, because if the patient is going into renal failure, if you give excess fluid, the patient will end up in pulmonary edema. So you give fluids and you look for jugular vein. If there is, if the jugular vein is getting full, that means that you cannot give any more fluids. And then give ASV, give fluids. And if you are, if you are suspicious that the patient is going into renal failure, refer to a place which has hemodialysis, right? Hemodialysis or peritoneal dialysis, that would be life-saving for the patient. Next. Cellulitis with necrosis. If you see, local toxicity in the form of necrosis, then you could give these patients antibiotics, and you can also give a dose of TT, right? And in case of viper bite, if there is coagulopathy, if the blood is not clotting, then it is not wise to give intramuscular injection, because it will cause hematoma as the blood is not clotting. So in case of viper bite, wait until coagulopathy is resolved, and then you can give tetanus toxin. Next, please. So recovery, you need to know what is the natural course of recovery, especially in case of viper bites, because these are the commonest bites that you would see. So swelling will take weeks to resolve despite giving ASV. So you have to, again, I mentioned this earlier as well, that it takes weeks for the swelling to resolve. So swelling has not resolved doesn't mean that the patient is not properly treated. Counsel the patient that it will take some time for swelling to come down. Coagulopathy usually resolves within 1 to 3 days after ASV. Neuroparalysis again resolves within first 1 to 3 days. So if these patients are really good to intubate, because on the 3rd day they will self-extubate, right? So you don't need to put these patients on ventilator for long times. Just 24 or 48 hours is reasonably good time. Kidney injury, the patient might go into oliguria, and then it will be followed by polyuria. So you have to watch for this phase, because acute tubular necrosis, initially you see oliguria or anuria, and then that is when the kidney recovers, there will be polyuria. So you have to give adequate hydration. So I had a patient who, who started going into acute kidney injury and renal failure, but then, improved with ASV. And then he started passing 4 liters of urine every day. So if you don't give fluids, extra fluids to this patient, they will get dehydrated and might develop electrolyte imbalance. Next. Then what is the key thing? This is something that if you're in PSC and if you can have sessions, or if you have some material, the ICMR has created material what to do, how to transport the patient. And I'm sure the link will be shared with you. So what are the key things? And key thing is immobilize the extremity that had a bite. Keep the affected limb below the level of heart while transporting. So if there is bite on the fingertip, when the patient is being transported, keep it below the level of heart. So if the patient is on stretcher, the hand should be hanging by the side. If the patient is walking, hand is anyway down below the level of heart. Do not use tight tourniquet. That cause more injury than more harm than help. Do not give cuts or suck the wound. I mean, fortunately, these days movies don't show sucking of the wound that they used to show in old Bollywood movies. So I hope that the younger generation is not growing up with that kind of perception. And do not give local ASV. Next. Referral. So referral is something that if you are in a region where you see a lot of snake bites, make sure you know the right referral center where the facility, if needed for intubation, is available. And it is usually good to inform the referral center that I'm transporting such and such patients. This may not be a normal practice, but you could be the trendsetter, and you could, if you know the MO at the CSC or district hospital, just message him, or someone who is on call, message them that I'm sending this patient. Please look after them. Arrange for an ambulance, call emergency, helpline, whichever is active in the state. Do not waste time getting an ideal ambulance. Once you have given ASV, the ambulance is not available, put the patient on motorcycle using the sandwich method. So you have a driver and you have an attendant and the patient sitting in between, and quickly transport the patient. Next. So if ASV is not available, for any reason ASV is not available, quickly transport patient to the PSC, nearest PSC or CSC that has ASV available, because time is very key when we give anti-snake venom. And if you feel that you have facility for anti-snake venom, then give anti-snake venom before you transport the patient, because if you spend time transportation, then the time to ASV will be delayed. So make sure you can start the ASV trip, and then you can transport if the situation is really bad. During life, this is something that during transfer, continue life supporting measures. So again, as I said, if the patient, for example, you have a patient with snake bite, crate bite, blood pressure is stable, you start ASV, and then you can, if the patient is having impending respiratory failure, put mask and bag, and then quickly ship the patient. If in case you don't have enough ASV, you're just given 3 vials of ASV, then write down that you are only given 3 vials and 7 remaining vials need to be given, because the other person gets a message that ASV was received and then they don't give ASV. So this is another practical issue that you need to remember, that the first dose has to be 10 vials. Next. So how to immobilize a person who, if, for example, the person has a bite on the fingertip or on the hand, this is how it should be immobilized. Next. If when we talk about tourniquet, this is a method to apply bandage, because the snake venom travels through lymphatics. So all you need to do is just obstruct the lymphatics. You don't have to obstruct the venous system or the arterial system. If you tie really tight tourniquet, what you're obstructing is arterial system, which causes more problem related to gangrene and necrosis. And you have to apply the bandage over a long distance. So gently apply it to the extent that you can just pass half of your finger. It should be so tight that half of your finger can pass under that tourniquet, and then it is applied over extended length of extremity. Next. Prevention of snake bite, again, these are simple things. Avoid sleeping on floor. Tell patient that don't sleep on floor. Sleep under bed nets if possible. Use of torch while going out at night, and use of shoes are simple things that can help reduce snake bites in your area. Next. So just to summarize what we have said. So major syndromes: progressive painful swelling you see with viper bites, neuroparalysis you see with cobra, crate, and sometimes viper bites. Vascular toxicity you will see with Russell's viper, and less commonly with saw-scaled viper bites. We have looked at their common symptoms: local necrosis, ecchymosis, blistering, painful swelling, compartment syndrome. They are occur with progressive painful swelling syndrome. Neuroparalysis, again, 2 Ps and 5 Ds that we talked about. Vascular toxicity, bleeding, DIC, shock, acute kidney injury. These are signs of vascular toxicity seen with Russell's viper and saw-scaled viper. Myotoxicity is very rare, so I would not be discussing that. Next. Next, we already covered this. So summary, give ASV only when symptoms of signs of envenomation are present, and then initial dose of ASV should be 10 vials, nothing less. Dose of ASV among children is same as that of adults, we already discussed. Adrenaline is the treatment of choice for anaphylaxis reaction, and also give it before starting ASV. So if you do that, the risk of anaphylaxis goes down. So if you forget everything that I said and just want to remember these 4 things, these are the things that you want to remember. Next. These are the references, and yeah, we can stop. So I'll stop with that, and I'll take, there is some question that I can see in the chat box. I'll take that, and then if there are more that we can take. Okay, that's fine. That's fine. Yeah. Yes. Oh, wonderful. So sir has already joined, so we'll stop here, and then we can start with sir's session.
Thank you, Dr. Yogeshwar sir, for his beautiful presentation. Simplest way to tell what to do, what not to do. Simplest thing to remember by forgetting entire lecture, but remembering just 4 things. Very, very beautiful way of presenting for our medical officers. How it occurs, what are the types of the snakes, how we can identify, what are the bites, what is the management, simplest way to deal with, when to refer, when not to refer. Yes, simply Avesa. So I request Dr. Yogeshwar sir to be here with us. We will have a question answer session at the end of our webinar activity. Now we'll move to the next speaker. He is none other than the Padma Shri Dr. Himmatrao Bhaviskar sir. He is MBBS and MD medicine, and he is a clinical practitioner of Mahad. I think I should not go for any details of Bhaviskar sir, because I think 99% of our medical officers and audience knows Dr. Bhaviskar sir. So I will directly jump on. I will request Dr. Bhaviskar sir to have his presentation, lecture, experiences regarding the practical approach of various types of snake bite management, various case stories, various case studies, prepared at the level of the medical officer, what is the preparedness to be done at the PhD level. These are the simplest things which we forget and jump on to very high funda activities. So I will request Dr. Bhaviskar sir to have his beautiful lecture for our audience, medical officers especially across the Maharashtra, and some practitioners also. Dr. Bhaviskar sir?
Yes.
Yes, sir. Please, thank you.
You are looking at my slides? Yeah, yes, slides are visible.
Yeah.
Yes, sir.
Yes, okay. You see, the previous author has explained everything. Nothing is left me to talk now on snake bite. To be
Sorry,
very
sir.
frank.
This is all learning from you, sir.
Now I joined at primary health center in 1976. That time nothing was available. No IV, no microset, no scalp pen, no cardiac monitor, no infusion pump. Only what was available to me, the BP apparatus, stethoscope, which has enlightened the scorpion snake bite mortality almost negligible. And what I feel, why I made a research. Visiting to the bed is a visiting to preliminaries. I never go to any temple. Next slide. नहीं आगे पीछे 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 So now this is our preliminary eras, pre-internet eras, typewriters, then writing ERMS, then projector 35 ms slides. This was very cumbersome to us to take so many slides with us to deliver it up to the peripheral taluka place, train the doctors, retype the papers, many spelling mistakes, many quarrel among myself and misses regarding public typing of the papers. Now today, see why we are immature, why we are innocent, why we are illiterate regarding the ruler science because of this. The students are not aware, not ready, or they are less bothered about snake bites, scorpion stings, and practical knowledge. They are interested in only neat, and neat. This has made the biggest obstruction in a practical knowledge. Now, why we should be updated? These are very important. Every medical officer, though, yeah, it's not an excuse that I'm medical officer, I should not be updated. That is wrong. Now, in today's internet era, everybody should be updated. Because it's why we should update. When I was in medical 1970, beta blocker was totally contraindicated. At 2000, beta blocker is the first drug of choice. These are the various newer things that appeared. Now, during that era, we never thought, we never dreamed that hemophilia will be treated. Now the drug has come, putasurine, as a treatment of choice for hemophilia. So science is advancing. You should be with the science. That's a very important. Even simple chewing of aspirin can give the life to the acute and then infant patient. That we should know now. Now, like important snake bite. See, this is very important. What? This disturb me more. Daily newspapers are irrespective of advanced knowledge, irrespective of repeated lecture to primary assert, irrespective of available antivenom and adjunct treatment, including ambu bag, intubation, and this ventilator, still deaths are occurring. Though the available antivenom, patient has reached from one hospital to another hospital, dies in the fourth hospital. This happened in last month in Raigad and Palghar district, Palghar area. So why this is happening? Because I came to know why this is number one thing. Still medical officers are afraid of anaphylactic reaction. So they should be well trained for anaphylactic reaction, how to treat the But I always tell the medical officer, if the patient is venomous bite, if the patient is carried cobra russell system involvement, if ASV is available, if ASV is given, if it have a severe reaction, you are given adrenaline, you are taken care of treatment of anaphylaxis, then he died. Nobody is going to. But if he is a venomous bite and you did not give ASV, he dies, you will be happy. So this is very important. We should know what a doctor has told now detail about treatment of anaphylaxis. Now, this ashram shop, this is a tribal school, neglected, almost neglected. Many tribal children which come in the morning death, unknown bite. What happened? Nobody knows are the great bites. Because these are there, they are overcrowded in one room. They never given the mosquito net and cot, though the government provides them grant for mosquito net and cot. So each and every child, they are the children of lesser God. They should be provided cot and mosquito net, which prevent the snake bite. And majority of the tribal community people, children are died of great bite. Now let us see. When I used to join to the primary health center, every day morning, patient used to come with a ptosis, pulling of saliva, respiratory failure, anemia. I was jumbled. I was not knowing at all what is happening. But I studied in detail because during my MBBS, nobody taught me how the snake bite presentation. What is the man? Even a scorpion bite, they say give adrenaline, which is contraindicated in the textbook. Here, we used to get morning ptosis, respiratory failure, hypoxia, patient is suffocating, and migraine faint with the detailed day in and day out study on treatment of the very nicely treatment with ESV, neostigmine, ambu bag, and ventilation. This dead morning we convert into good morning. Here it is a simple treatment which is available at primary health center. We can give this slide because this is an acute, life-threatening, time-limiting phenomena. Don't shift your responsibility by transferring a patient in acute respiratory distress. Don't shift the patient in availability by antivenom without giving ASV to the victim with a venomous bite. So very important. Transfer doesn't indicate you have shifted your responsibility. You have taken more responsibility on your shoulder if you transfer patient without giving ASV. Now, why we are late? Why we are late? Most still patient is going to faith healer. But what happens when the crate bite victims come during midnight? How I treat? The always crate bite victim accompanied with the more than 50% during night in my area that time at PSC. So I train the doctor, train the relatives. Why this snake bite, crate bite has occurred? Because he sleep on floor base. There is no proper closing of the door. There is outlet is not properly shelved. That is the bathroom outlet. These are the entry. And most important, treatment is available. And if you give the cotton mosquito net, can be preventable. And never go to this PEX or a health healer, that is tantric. Why? Tantric going is totally banned in my area because the patient come to know the rapid good recovery free treatment is available, and patient can be saved. Patient can be brought back to the from dead bed. That's what they got more faith in the medical science. This is the achievement of medical science, ultimately abolition of tantric people. Shortage of doctors. There is no shortage of doctor, my dear friend. The doctor is not available during night hours because fights occur during night hours, and there should be available for doctor night hours. Most probably, what I feel to the government, if the doctors stay night out, they can be paid more extra money to pass a night hours in the PSC, so many patients can be served. Next important shortage, antivenom cannot be short. Government has enough antivenom, and all PSC got enough antivenom in all over the Maharashtra. Then delayed diagnosis, illiteracy of a doctor. Now our previous speaker has given detail how to diagnose. Delayed diagnosis commonly occur in the grade bite. Patient come in the midnight or early in the morning with a pain. He woke up with a pain in abdomen, vomiting, sweating, as if he is feeling indigestion. He has no. He don't say do not give the history of snake bite. He say rat bite, no bite at all. He may get a heaviness in the limb. And then is a pain in the because release of acetylcholine from the acetyl vesicles, and then blocking of the receptors, and we get vomiting, sweating, a pain in abdomen, and morning we get ptosis, pulling of saliva. That is heaviness of the eyelid. Now here we confirm if the patient of healthy who slept, who was healthy yesterday, woke up in the midnight from the floor bed with a pain in abdomen, come with neuroplastic, diagnose crate bite unless until proved otherwise. And that is why the crate bite never bites, because let us see how the bite snake fangs are. Any inadequate illiteracy of a doctor. Now, by this indicator of the two lecture, all doctors should be literate. Ineffective antivenom. Many times antivenom may not be effective because the venom is prepared from Urula community will capture a snake in Chennai. So we must have a regional variation of snake toxin. So that's what we advise to the government, which are published long back, that there should be regional venom antivenom bags to reduce the dose and effective dose of antivenom. Suboptimal supportive care. One, just to give 2 ampoules of send the patient. Don't put an ambu bag and send the patient, and not give any minimum treatment, and just to shift the responsibility will kill the victim more. Now, what are these are for big. Yes. Now these are the big snake. This is a crate. Look at the crate. Crate, I say, is a mature snake. Crate is a terrorist snake. Is a silent killer. I am using the word 3 appropriate to the crate. Is a mature, is a terrorist, and is a silent killer. Because it is nocturnal habit, it enters the habit during the night hours, its fangs are very small, it injects the venom, which is a very venomous than cobra, though the small size, venom is slowly absorbed, because during sleep, skin circulation is poor, it is slowly absorbed. Cobra bite. Now, this is a cobra we say around the rubbles in the attics or any dry woods or loose stones where there is a cobra. Loose in the cobra bite, there is severe local pain, and patient can easily recognize a rapid deterioration of death can occur of cobra bite. If the patient comes with a cobra bite, I have seen a patient was brought in a rickshaw with a cobra bite with a respiratory failure, growth in the mouth. We give him a neostigmine first, atropine and neostigmine, then ASV, because we resuscitated the muscle first, respiratory muscle, and that ASV. So here, postsynaptic receptor, which is blocked, reversibly blocked by the cobra venom, can be reversed by neostigmine, and yes, we will take care of circulatory venom. So in acute respiratory failure, in cobra venom, we have to give neostigmine. Now, Russell viper is the enemy of the farmer. It grows in sugar cane, soybean plantation, jungle, and it injects because of fangs of deep intramuscular, and you get a muscle swelling, muscle pain, big edematous, fluid is locked, and DIC, local DIC. No soon fangs are removed, the bleeding oozing start. So this oozing start confirmed. No need to take test or 20-minute clotting test. Already blood is not clotted. We have to give ASV. Now last is the most mature again is soft-scaled viper. This soft-scaled viper grows in the grown-up grass and on the rocks. When the farmer is walking through the grass, it bites and runs away. It is rapidly very active. So the formal field is a thorn free, can never give the history of snake oil. But this is very important. A brilliant doctor who is aware of doctor knows why occur if there is local edema, if urticarian edema, lymphadenopathy, confirm the snake bite because thorn milk will never give such manifestation. Now, what are the risk factors? Now, the very important risk factor is this firewood, bluestone, waterland dab houses. These typical waterland dab houses in our area, which is the commonest cause. Now, the harvesting the grass, left hand goes blindly in the grass, walking in the barefoot, walking the this soybean plantation, we get Russell vipers. Now, next important is worst is risk factor is this. If the tribal person who is a poor man, who is an illiterate person, he is not knowing his rights, he stays in OPD with a snake bite. So this patient, if you allow him stay in the snake, this patient in the OPD, you are adding his day because of venom. But bite bite to the needle, just like the bite to the needle increases, the envenomation is increased, and that's why patient should be in OPD patient. He should be given first preference of the treatment. Migrating population. Then how the patient was brought to me in Dolly basket. During that in 1970, now it is vanished. Now this look at say how clinical. See, this is a crate. Local sign. Local sign may not be present at all, and the crate can bite anywhere: axilla, scrotum, back, and knee joint, anywhere. And look at this. The vital fangs occur, and there is urticaria around it. If you get a magnification lens, then you can. When you get a patient of unknown bite, you just survey the whole body whether something is there bitten. Of course, you start the treatment, and then you can see the urticaria. If there is fangs mark with urticaria, confirmed patient is in venom. Now we can get a ptosis, we can get a pooling of saliva, rapid recovery. Now the cobra bite, severe local bleeding which occur, edema occur, ptosis and rapid recoveries occur by the cobra bite. Russell viper, a big edema, this compartment syndrome, dry gangrene, big stance, 75% venom is injected, which cause local DIC, bleeding disorders, thrombosis, and gangrene and edema. Bleps can occur. Bleps can be drained out by the sterile needle, and hematoma, continuous flow, shower of the blood, which occur because of CID. And lastly, we get capillary leak syndrome. Now, the capillary leak syndrome is a number of various etiologies because tumor necrosis factors and various interleukin has increased. And this is Russell viper delayed manifestation, which cause conjunctival edema, renal failure, ascites, and a hypotension, and swelling like this. Patient has raised creatinine level and face become triangular like a Russell viper. Russell triangle is called Russell triangle. Ichthys carinitis, you get mild local pain and even stroke, which can occur in ichthys bite. Now, what Kopte Aman said, it is the biggest health crisis you likely never heard of. This sentence would have come from Indian scientists, but it is coming from the Kopte Anam. So this is really biggest crisis. Now it is we never heard of. This is very important. What's the global burden of snake bite in is published in the Journal of Royal Society. Now, what are the manifestations of clinical pathogens? Just in short. Cytotoxicity, lysolecithin content, which destroys the cell membrane, which is the lesion pattern, because of local damage of lysolysis cell membrane, healing is delayed. That's why healing takes months together because of loss of cell membrane, loss of vascular structure, loss of capillary. Neurotoxic. Now there are neurotoxic which occur. There are two types of neurons: presynaptic and postsynaptic neurons. Presynaptic neurons are blocked by irreversible blocked by the beta buncotoxin. That is a crate which destroys the presynaptic receptor. We call neuroparalysis, and that's why recovery in weeks, because recovery depends on the regeneration of the receptor. That's why in case of the crate bite, if you go earlier, so if you give maximum, what was said our previous author, that 20 ml, 200 ml of PFC. So minimum venom will use to the receptor, minimum receptor will be blocked, and maximum receptor will preserve. So recovery will be fast. Similarly, post-neurotic neuroreceptor which occur in the cobra bite are reversible. Hematotoxicity, which are commonly seen in Russell viper bite because of the cascade, the derangement of coagulation cascade, activation of coagulation factors, and prothrombin to thrombin, and blood become liquid, and patient get a hemoglobinuria, hematuria, bleeding diaspora, deicing, DIC, and we are bleeding from the ear, nose, throat, and bleeding in the abdominal cavity. Patient will have pain in abdomen. Unknowingly, suddenly shock. This indicates bleeding is the pain. Bleeding around the big hematoma around the renal tissue can cause renal cardiotoxins, which are commonly seen in the cobra bite. As cobra contains a tumor necrosis factor and cardiodepressor factor. Various blocks. Cardiac, we have seen a ventricular arrhythmia, which need DC shock and ultimately recur with ASV. So cardiac arrhythmia, which can occur because of this and cardiogenic shock. Myotoxins, which is not seen in Maharashtra, but it's commonly snake. We call rhabdomyolysis and liberation of potassium. We get trismus, respiratory failure, severe muscle pain, wasting, and patient get hyperkalemic cardiac failure. And this we have to treatment very nicely with a drug which should be available, which is not mentioned, that is calcium gluconate. First available is very important. Then insulin glucose drip, dialysis, diuretic, salbutamol. If nothing is available, if not responding, resistant potassium toxicity can be treated with levodopa. And nephrotoxicity, which I have seen in the Russell Viper biochemistry, just author this previous readers has already detailed about nephrotoxicity, antigen antibody reactions, the interstitial nephritis, blockage of the tubule pipes, release of the glomerular, release of hemoglobin molecules, and next important allergic nephritis, which can occur, which is treatable with the dialysis and adequate ASU. Now Russell Viper, various sizes of Russell Vipers are there. Now this we have just said, no soon bite occurs. Bleeding start from that is a local DIC. Bleeding, this is a wet gangrene. Look at this, edema of the face. This is one of the Gadchiroli patient and part of Kerala. We get neuroparalysis with a Russell Viper bite, which is commonly seen in Sri Lanka, needs ventilator, but India we rarely need. But there are reports from Kerala that neuroparalysis can occur with the Russell Viper. Here we make a confused with the cobra bite. Cobra bite bleeding disorders rarely never occur. In the Russell Viper, we get bleeding disorder along with neuroparalysis. We get compartment syndrome. This is because of compartment syndrome is very important. Large volume is locked in, and that's why patient may go is hypotension shock. One of the cause of the shock is compartment syndrome. Next important, the vein, the pulse may be seen. It doesn't exclude the compartment syndrome, but very important, you demonstrate hypostasia, nerve passing through the compartment syndrome is a diagnostic, and treatment of antivenom will solve this problem. Minimum dose of laxative even reduce the edema. Most important, never hand over the patient to the surgeon unless and until deemedly required when the coagulation factor is completed. Many times we get a stroke, watershed, infarct, hemorrhage, infarct in the brain. Stroke is presented and this hemiplegia, but many times this stroke is recovered. Now, two types of bleeding disorders can occur. Urine can occur. Black urine, this is called hemoglobinuria, where the hemolysis has occurred. This is a late phenomena which occur hemolysis in the blood. Hemoglobin is molecule is liberated, leaches in the capillary kidney and liberated like a brown color. But when there is RBC are liberated, earlier stage, when RBC are liberated, we get hemoglobin, hematuria. This is hematuria, hemoglobinuria, and regional lymphadenitis. Where is a diagnostic of the Russell Viper or Viper bite? We get ecchymosis, regional lymphadenitis, and parotid swelling, which is a rarely occurrence in the Russell Viper venom, along with the capillary syndrome. Now, hemoptysis, epistaxis is very common. Continuous bleeding from bite start, continuous bleeding. And look at this. With this patient has injury, old injury. He has a Russell Viper bite. That's old injury started bleeding. So be care of old injury, which can again start bleeding because of bleeding disorder. Patient can't is a local bite mark like this. Now here is a question: when to give antivenom? You do wait for the 20-minute clotting test or not? You see, nose on the venom is injected. Injection of venom followed by the small swelling. This is swelling. Swelling means venom has injected. If and this venom will go to the circulation, it will take few hours to form the blood to be incoagulated, and then our 20-minute clotting test take out. So 20-minute clotting tests are indicated for re-administration of antivenom, not for diagnostic. The first diagnosis of edema, nose on the edema upper, you start ASV, irrespective of whether the blood is clotted or not. Next important, look at this. You see, I received at midnight a call from Gadchiroli that doctor has said there is a snake bite case, and he has shown me this is some site of the. After 1 hour, After 1 hour, she showed me send me this photograph. The blood become incoagulable. But this snake, when he has shown that this snake is a non-venomous. This is look like a Russell, but see the Russell's neck, this separate neck is like that. It is slide with the body. And next important is look at the shadows of this is not like a Rudraksha. It is like a Rudraksha here. This is the Russell. Look at the tail. Tail is slender in the Russell is not tail. So this was a Russell sand boa, non-venomous. But I was in dilemma. Already has given 10 ampoules of PFC looking at this thing. And then I'd asked him, which is the tube? So it was a plastic tube. Never do 20-minute clotting case in a plastic tube at all, because plastic tubes interfere with Hagman factor and patient may be blood may be incoagulated without envenoming. So be careful. The plastic tube should not be used as previous author has made it. New glass test tube, new dry glass test tube should not be washed with a detergent. That's a very important. Asham on the part of government that one PSC, when I say you have got a tube, they say, doctor, we don't have a test tube. So this should not happen. We are heavily, we are lakhs of rupees are bidding for, we are for 2 bit of the bidding, and we don't have simple test tube. Every PSC must have this instrument available because it is a simple test which can be done by one boy. Next important, looking at this, already saying hypovolemia, swelling, passive movement, pain, hypostasia, intercompartment pressure, pulsation does not rule out. That patient does not. Movement, your 20-minute blood should be clotted, and this is a big hematoma. Remember, in earlier stage, when the patient of snake bite come with edema, never lift that limb at all. Never put the pillow under that limb, because the venom will be rapidly absorbed in circulation and patient will land in the massive pulmonary edema, severe respiratory failure, or DIC. So when after then and then you can low down the patient of edema. Now, rarely we can see importance is to look at the palate. Many times the patient comes late and palate petechial hemorrhage, again a diagnosis of Russell Viper bite or Ichthys bite. Now, many times we can get a capillary leak syndrome, conjunctival edema. This is a conjunctival congestion. Look at congestion. Edema, bleeding from the lungs, capillary, bleeding in the lungs. We get hypoxia, lung bleeding, which is like persistent hypoxia, ARDS-like phenomena, and we can get capillary leak syndrome. So capillary leak syndrome is the worst, with the prognosis is very bad. Now, why there is capillary syndrome with the Russell Viper is a various factor. We get the edema, we get pleural effusion, we get the gastric dilatation, gangrene, and what happens to the liberation of protein material, extracellular material, hypotension, hypovolemia, cytokinin, TNF, intolerance, and toxin, which is liberated, which cause the capillary syndrome. And treatment, very important. Though the child is edematous, you will have to go very closely monitor fluid resuscitation. You can give specialized starch and albumin, steroid, aminophylline, theophylline, terbutaline, and steroid is methylprednisolone is a drug of choice. But important, if this victim get earliest mode ASV, they are less likely to develop capillary leak syndrome. Now, this is Russell Viper. We can get a neuroparalysis of bleeding. Now, hypotension which occur in Russell Viper, one of the cause, you see, this venom is rich in bradykinin. No sin bite occur, patient falls, suddenly fall down because of jungle that shepherd or even a hefty farmer no sin bite fall down because of it is rich in bradykinin, which can stimulate the nitric oxide liberation and hypotension. Bleed from pituitary, many times bleeding from pituitary cell in them for hypotension, CN syndrome, amenorrhea, which can see later on life. So this should not be neglected. Adrenal bleeding patient gets severe hypoglycemia and hypotension. Perinephric hematoma, which can occur, which causes severe backache, animal. Acute bleeding in peritoneal pleural cavity, compartment syndrome, hematuria, capillary syndrome, and DIC. Now, DIC, the problem of DIC, when we are given ESV, patient of a couple as of previous author said 30 ampoules are completed. Still patient is bleeding. You can take a blood pill slide. If the criminatal RBC confirm DIC, and DIC will well need. It's a job of hematology that a FFT of plasma is required. That can be reversed by the DIC. Now, renal failure, which is common seen because of hypotension, because of compartment syndrome, cortical necrosis, interstitial nephrosis, antibody, blocked tubules compared. Now we have seen a rapid fluid resuscitation, Then we have to take up a electron imbalance, maintain the nutrition, dialysis, and in case of peritoneal dialysis, electrodialysis, or post-dialysis, which can be possible. But this, what I observed, suppose the patient, commonest cause of renal failure is a Russell Viper or rarely a Ichthys peritonitis. But if the patient, now that data is going on. Yesterday, we have treated one patient from Paramati. Patient has come with a big big snake bite, Russell bite within half hour. We advise him 200 ml of PSV stat. You see what happens. No sooner you give maximum dose, maximum venom is neglected and neutralized. Next important, the edema also reduced because occurrence of edema again give the protection to the venom to be accumulated there, which can act slowly as a depot and patient develops severe manifestations of renal failure. Suppose you get maximum 20 venom, 200 ml of ESV, minimum edema occur, minimum venom is local stock is occurred, and maximum venom is neutralized, circulating neutralized. So ultimately, we have to differentiate between Russell Viper and a small python. So infant python, many times child person come with infant python. Look at infant python is a clearly differentiated. Even boa, this is in non-venomous boa, and this is Russell Viper. So this we have to differentiate, or unnecessary we are exposing the person with ESV, which may kill by antibiotic reaction. Now, if the bleeding is persistent, because what prothrombin is thrombin form, on thrombin the fibrinogen is deposited, then fibrinolysis occurs, patient develop DIC. Now we found that tranexamic acid, which antifibrinolytic factor, may be helpful to prevent, to continue the bleeding in this victim. Now, crate. Let us see the crate. My dear friend, crate I talk is a mischievous, terrorist, silent killer. His venom is 10 times venomous than the cobra bite. His fangs are small size, like insulin needle. It injects the venom. It during the night, it's a nocturnal habit because during heavy rain in July, August, September, the grooves are full of water and it's a breeding season. It enters in the house in the early night. Snake has no ear, so it can perceive the vibrations. When everybody goes to sleep, nobody walks. There is no disturbance of sight, no vibration. Crate woke up in the midnight and entered in the house. After entering any sleep below the door or from the bathroom outlet, enter in the site. While going to enter, it finds a way in the building, which become hot and it's a pleasant climate, enter in the building, and during the second REM sleep, there's involuntary movement of the movement of the body. It takes misspray as a hunt, and it bites to a person. And after bites, the skin is inject the maximum venom by the small fangs like insulin needle. So patient is because of during sleep, the reflexes are blunted. Skin is poor circulated, poor conduction, circulation of skin. So poor venom is slowly absorbed. That's why early stage, what happens? Because of venom, releases acetylcholine from vesicle cycle. We have acetylcholine vessels, so we get vomiting, sweating, pain in abdomen. Many times there is polycystic iron liberated and gallbladder pain. That's why pain get a severe pain. Number of times, patient get a chest pain with a hypoxia ECG changes, and patient is admitted in ICU as a myocardial infarct. Many times, patient the pain abdomen vomiting. So diagnose appendicitis, and morning they diagnose respiratory failure. Many times they diagnose hysteria, encephalitis, meningitis, what not in which case, and number of unusual and junior most trained doctor from primary health center come in the picture and say it is a crate wise whole diagnosis change. Now, very important is the broken neck sign which occurs. It is where to indicate. Indication of intubation is one. Pulling of cellar. Power, grade 3 power are unable to lift the neck. That is indication of intubation. May not need a ventilator, but intubation is very, very important to prevent aspiration. Neck has internuclear ophthalmoplegia, which can look at this. Internuclear ophthalmoplegia can occur. And dilatation of pupil. Now, dilatation of pupil in a crate bite doesn't indicate irreversible brain death. Look at the pathophysiology of this. Now, the iris is a reach in the capillary and reach in smooth muscle, because that's why no sooner put a light, it contracts rapidly. More acetylcholine, more venom goes, more receptors are blocked, so we get the paralysis. So doesn't indicate the irreversible brain death. Now this patient has recovered, though there is dilatation. So remember, a 4-year child was brought to me with a date. They said child is dead without auscultating. I just seen the child dilated. Child was one bit. I resuscitated child, and child was discharged. Next important thing, I am telling you here only how to diagnose whether patient is conscious or not. If the patient is locked in syndrome, quadriplegia, total paralysis, levator palpebral superior is a recent acetylcholine receptor. That's why they are most primarily affected is levator palpebral descending neuropathy because all descending muscles are more actively involved. Face muscles are more rich. Thousands of face muscles are rich in receptors. That's how we get myasthenia-like look in the crate bite. Next important ptosis. Levator palpebral is rich in high concentrate. One neuron supplies to the 8 to 10 neuron of 10 motor fibers of levator palpebral superior, while one neuron supplied 1,000 to 2,000 voluntary fibers. And because of this, these levator palpebral superior more fibrous, more affected, and that's why there we get the ptosis. Next important, levator palpebral superior is bilaterally innervated by the patient nerve. Now, when the patient is totally quadriplegic, whether he cannot move at all, so whether we should know whether patient is conscious or not, because pupils are dilated. And now, my dear, you just put your hand over the skull, frontal skull, and just murmur in the ear of the patient. Look at up. Slight fine moment, you'll gauge up the levator palpebral, confirm the patient is conscious, and that is very important. Patient is going to recover. Next important, the recovery is followed, preceded by appearance of ankle reflex. So ultimately, look at this patient. This last month, this young girl, a beautiful girl, was brought dead to me in the morning. That she was beaten by the crate and brought dead. And just now, you see, irrespective when or coming, when the relative 1,000 relative, I advise them keep the mosquito net, mosquito net, mosquito net. Indian culture is total. This is Waterland Dam house. See, look at this out where the crate they have brought and this woman died. They got to this, which is expensive. It can produce a 10 mosquito net, but they produce a dish. That is the Indian culture. We don't know which is protective. Now, the important thing is the patient come late, the mortality is late. So patient will, after 10 hours, maximum patient will be brought dead. So ultimately, intubation. You must do a timely intubation. If you fail at doing a timely and untimely intubation not done, patient of brain damage and irreversible vegetative. Simple intubation, ambu-bag ventilation can save the victim. Now look at this patient was brought with a crate bite in the morning with a so big crate, and this is a slit through the crate has endured. Look at this is a poverty. We never charge this patient. We give all free service to the primary health center or rural hospital. And most probably last month only I will see the child. So we are paid. Have a good door, boss, because they say 3 times over I've seen the crate coming from this door. So it is immaterial for me to pay and to give them the new doors. Look at the crate, is a nocturnal Thames poison, sleeping on the floor, wait. See how I analyze. This is a good story. You see there, last 3 to 4 months, 4 years, there are near about 30 cases of crate bite only from Hindus, not a single Muslim came. So I was in dilemma. How Hindus are coming with this? So now there is one village where 50% Muslim and 50 Hindus. Where from village 5 Hindus has come of crate bite. So I gone in the place and to study the sleeping pattern of Hindus. Richest Hindus sleep on the ground floor bed. Richest or poor Muslim sleep on the cot, or they can use very nice mosquito net. So ultimately research has come out that mosquito net prevent crate bite, falling snake on the rope, that is snake bite, and this scorpion bite, and mosquito bite, malaria, tuberculosis, encephalitis, dengue fever, and chikungunya. So one in multiple. So this is simple research which we published long back in the Lancet. What they say, even the research, Donald Ross has said 20 years he has used mosquito net and only twice he had an attack of malaria. So this is so important of the mosquito net. That's the most important of the important mosquito net. Look at, and now when the patient of venomous bite comes to you, You are diagnosed, patient has venomous bite, there's a local sign, patient come with a tourniquet, this is a myasthenic look, this is a pulling up saliva, never release the tourniquet, caveat, unless until 10 vial of ASV is infused. Otherwise, patient will die because of rapid absorption of the venom, and patient will die. This is very, very important. No tourniquet should be released unless in full dose of antivenom is given. Even bites, great bites can occur to the nose. Look at this. And look at this, a great bite. See a small pinhead bite. Patient come with a pain in abdomen with a broken neck sign, and patient recover. This is a dilatation of pupil again. Now, there are 3 stages of the great bite. No soon bites of multiple bites. Patient can have multiple bites. So soon, within half hour, patient gets a deep paralysis. That deep paralysis, anoxia of brain, plantar is extensor, totally depressed. 2 to 3 hours, patient get a first is a profound paralysis. 2 to 3 hours, patient get a deep paralysis where reflexes are absent. Quadriplegia. Patient is unable to move. Bilateral ptosis, dilatation of pupil, and recovery started. 2 to 3 weeks, and recovery will get all. During these 2 stages, earliest profound, profound paralysis, we get reflexes are present, but profound paralysis, reflexes, deep paralysis, reflexes absent. So look at the ankle jerk. In a neuroparalysis patient, wait till the ankle, patient is serious till ankle jerk is elicitable. Probably not diabetes. You have nose in the ankle jerk is elicitable, patient is recovered. So next important again, dilatation. Look at this is dilatation should not taken as. Now look at last muscle to improve the great bice is the proximal muscle. Because of this is the biggest muscle to recover from the great bice. Now look at this is the last month. This child was brought from here, Waterland Dab House, just like the jungle area, and this was a great. So this is more than 7 feet kid. I received a phone call at the midnight, 3:30 a.m. One of the doctors from Kolhapur is called me. Doctor, the child has come with a big crate and is beaten to the neck and hand. So what to do? I say give 10 ampoules of ESV first. 10 alpha, yes, we are given there and shifted to the Mahad. In the Mahad, we treated the patient, and now after with the treatment of patient, a patient told, and look at this. This is the slit underneath the door. This slit is underneath the door. This is crate has entered, and parents say near about 2 to 3 times crate has entered, and this is a welcome. Crate is welcome to this, and this is side, so local to the ear side, and patient has a neuroparalysis. Look at unable to bring the mouth. Pulling up saliva. Look at the pulling up saliva. Look at the ptosis, and it's a pulling up saliva. Broken neck sign, typical broken neck sign. This is a typical broken neck, and ultimately patient recover. July, this is less July will go. Reflexes present, and this only 200 ml, 2 doses neostigmine, calcium gluconate. Calcium gluconate is very important because it increases neuromuscular conduction and 6 hourly ringer lactate antibiotic. You see, when the patient of great bite comes, after yes, we have to take 3 cares. 1, nutrition, oxygenation, electrolyte balance. If you take care of three hemodynamic, three things, patient will recover. Next important, many times patient can get it. You see, pulmonary edema now. You see, I say great bite is a presynaptic blocker. Now, postsynaptic receptors are adrenaline secretion. Presynaptic receptor inhibit adrenal secretion. When the great bite block the presynaptic, adrenal postsynaptic receptor release, so we get hypertension in the great bite. Many times great bite get pulmonary edema, mark hypertension. One should care of this and always take the BP of the great bite victim. And remember, when the patient is recovered from the neuroparalysis, the first shift should be given by the doctor himself, not by the nurse and not by the patient or relative itself. Many times this shift may cause sudden bronchospasm, laryngeal spasm, or cardiac arrest. So you should be present there to give the first shift to the patient. Now look at this crate. This is a bite, licks, crate. Rural area, they say that crate licks the skin. I coined the term in tropical doctor that crate licks the skin and bites the respiration. Just like rheumatic lick the joint, bite the heart. Crate licks the skin and bites the respiration. This is public in tropical doctor. In a cobra bite, we get, everybody knows, hypersensitivity, sudden death, catecholamine excess, ecchymosis, Pang marks, and patient can have respiratory failure, ventricular arrhythmias. Now this patient is 90 minutes, recover with a 45 minutes, and total recovery, but wound takes a long time, days together for recovery. So cobra bite recovery is very fast. Now this patient, look, this is a telemedicine. This is called telemedicine. I received a phone from the Kolhapur in the morning, 8 a.m. That doctor says the woman has just lifting a bed sheet from the wall and something is bitten. And she is doing some abnormal movement. Doctor cannot diagnose. She's a disturbed, and there was appearing swelling. I say it's a cobra bite. Start ESV. Give neostigmine. Patient was treated at that PSC only and discharged from PSC and total recovery. So this is important. Time limitation, life-threatening emergencies, proper advice, proper administration of the drug will recover. So it is a science, it is a knowledge, application of knowledge in time will help to the victim. So ultimately in cobra bite, one should care that cobra bite relapse can occur because of local edema which comes of the depot. So after 24 hours, relapse can occur. So minimum 3 to 4 days cobra bite should be observed. Now, what we did in Aheri, you see, intubation. Intubation is very, very important. Our medical science is still incomplete. The doctor of MBBS degree should not live unless he is a proper intubator. We arrange the big camp in the Aheri where snake bite was very common in Gadchiroli district, and we train all the doctors on mannequin with a ventilator, proper intubation. Unless they succeeded, never leave the mannequin. 10 times, 20 times, 40 times, we never laugh. And everybody was trained how to intubate. Next important neostigmine, which was detailed discussed just now by previous author. Now another, can neostigmine helpful is a simple test. That is, you can put the eyes back on the ptosis eyelids if they are improved, because hypothermia sensitizes the receptor to acetylcholine. They are improving, then this patient is likely to improve with a neostigmine. So calcium gluconate is helpful for neuromuscular. Now difference between crate and wall snake. Many times patient come with this snake and relative say this is a crate and give the ESV. An illiterate doctor give the ESV and kill the child by ESV, reaction out, unnecessary waste the ESV. This is how to different. Look at the tail. Tail is free from white band is a wall snake. You look at the tail, the white band is at the tip of the tail. So this is different between the crate and wall snake. One should remember. So now no news, no, antivenom is not contraindicated at all. When needle issue, adrenaline should be ready as I discussed. Polyvalent, no test dose. In normal saline, no intramuscular, no other site of bite. Doctor should sit by the side of victim. Antivenom, neutralize circulating venom, behavior of adjuvant treatment. Don't feel antivenom given duties or we have to give neostigmine, we have to give calcium, we have to look for equilibrium balance, we have to seek back oxygen, we'll need ambu-bag or ventilator. Now this looking at the preparation of antivenom, that a powder form. If it is a turbid, throw it away because the protein precipitated make you severe reaction. So how to treat how the anaphylactic present, remember? If you sit by the side effect, first sign of anaphylaxis, hotness in the scalp and ear. कानामधून वापा निघता hotness, and then remaining hypotension, tachycardia, swelling, angioneuritis, edema, urticaria, all everything occurs. And treatment, first treatment, what we discussed is discontinue the treatment. Head low position, adrenaline intramuscular, steroid, antihistaminic, IV, SU block, oxygen, aminophylline, intubation. And then if doesn't respond, you can repeat 3 to 4 doses. If doesn't respond, then what to do? You can give IV adrenaline, 1 ml of adrenaline, dilute 9 ml of saline. So 1 ml contain 100 micron, you can give IV 5 hourly. If doesn't respond, and patient we have to give ASV, change the batch of ASV, because that horse venom, horse serum may be sensitive, highly sensitive, allergic to this victim. You can change the batch of the ASV. So ultimately, adrenaline was given. Now this is a Russell. See, look at the one hospital, 200, how much? 1400 ml of ESV given, where the 14 can be treated. Next important, dilated. Now, which patient should be resuscitated? Now, if the patient cause dilatation, diffuse, and cornea luster is normal, cornea is not losing a luster, most likely brain is intact, you can resuscitation recovery. But if the cornea is losing a luster, lusterless cornea, hypoxic brain damage has occurred, and such a child we can resuscitate the child, but child will be vegetative stage, extra load the family for throughout the life. So this is very important decision to be taken. If the luster is lost, you are less likely to succeed to get a normal life or normal resuscitated child. Same is true this. Now, Echis carinatus, we have just seen a Sosket vapor bites and run away. We get a hematemesis bleeding and say bleeding. Local tap, 20-minute clotting test will be helpful. Now, various other, green pit viper, then these various snakes which are saying is not available. But now there is a paraspecific system. Polyvalent may work here because of many toxins are almost similar. So the structure is almost similar. So you can give the polyspecific, take the advantages. You can give a polyvalent antivenom. Now the very sea snake, we get trismus, tented, TVO, even the green pit of huge edema we get. Otherwise, we have to observe the patient. Now, no local edema, which are just now will cause hematoma, and this is sea snake, ptosis, severe body ache, angioedema, foreign body sensation, muscle weakness, respiratory paralysis, tented TVO, color urine, rhabdomyolysis, hyperkalemia, and now the treatment of sudden release. Now remember, when the patient come with the two multiple tourniquet and the snake brought is non-venom, still never relieve the tunicus rapidly, please. Because this rapid severe vasoconstriction, severe tourniquet, upstream blood, there is accumulation of rapid lactic acid. And lactic acid release will cause sudden cardiac arrest, those venom. So how to release? You can apply BP cup to the thigh and slowly raise the BP and slowly release, and then you can remove the tunicate. So ultimately, my dear friend, what happens? This is now New York Guard gate patient can bring the photographs of the culprit in the mobile phone. You can show them photographs. Now how to travel, I will discuss. Now mosquito net will prevent this as published in the Lancet. Next important, I train the doctors in the cattle shed at my own cost and mortality is reduced. Important thing is a mosquito net age which should be tackled under this. Now remember, this is what happens. Now the color of the snake. Look at, if it is a dark color skin is a poor conductor of the heat. It is a cold-blooded animal. This is a cold-blooded animal. And this dark color skin, because it's broad day, notion white upper within 1 to 2 hours broad day. Dull color skin is a poor conductor of heat. So the body of the snake is a temperature raised. So venom is in liquid form. So at one bite, rapid speedily in that second, rapid speedily maximum venom can be injected. While the less dry skin is a good conductor of the heat. Body temperature is low, so venom is viscid form. And because of less venom is injected, that's why black cobra and the sound cobra. This black cobra is more dangerous, hazardous than this cobra. And that's the reason why the patient will die rapidly while this patient recovers. Now, mosquito net is the most important thing. What I feel when you treat the patient, what I feel duties done, earning members of family say we are one of the server of national we say he may be father, mother, wife, husband, social worker, he may be scientist later on. We get the doctor gets esteem satisfaction, and most important, what doctor gets rather than money, he's become rich in academics. His academic reach by experience and competence for is the next big theme. So various medical sciences, venom has still medical science. Mycin agree with Dr. Antibody, coagulation, because you see, McFarlane is a brilliant scientist with Nobel laureate, added the Russell Viper venom in the hemophilic blood clotted, and he elucidated the coagulation cascade and got Nobel Award. My understanding is etiology. Clotbuster, AC inhibitor, we came from the Russell Brutus venom, we got a AC inhibitor, sesamology, saprotoxin, complement activity. And now I am coming to thesis that rabies can be treated with bungotoxin, which is underway. Now, thank you. Okay. Any question? Hello? Hello? Hello?
Sir, thank you very much.
Any question?
Yeah, we will take on the question, sir. Yeah.
Any questions that they have? Right.
I will just search the question in the chat box,
Yes.
and then we will discuss our pre-test paper having the 10 questions. I requested Dr. Yukshaswar also to discuss these questions. So we'll start the first these 10 questions, sir.
Okay. So the first question for everyone was which one of the following is not, which one should not be done in managing snake bite? First option was keep the affected limb immobilized and below the heart level. Second was apply a constriction bandage proximal to the bite site. Third was seek immediate medical assistance. And fourth was reassure and calm the person. So what do you think is the right answer to this? What should not be done? Keep affected limb immobilized and below the level of heart. Apply a constricting bandage, seek immediate medical assistance, and reassure and calm the patient. Please either speak or you can type in chat box.
I have to answer for the medical officer.
It's for medical officers.
Okay.
Okay, there are some messages coming. You can scroll down. You can speak as well. Those who can speak, please speak. Go down. Okay, can I call on? I see Dr. Dattatray Chauhan. Can you give the answer, sir? You're on mute, sir.
You can unmute yourself.
Okay, so which one of these is?
Yes, this is not done in the snake bite, sir. Constituting to proximal site of bite.
ठीक अगदी बरोबर. आणि उत्तर मराठीत दिले तरी चालतील. We need not answer in English. The second question is which of the following venomous snakes is responsible for majority of poisonous snake bites in India? Can someone answer? The options are cobra, Russell's viper, sea snake, and crate. No one is answering, then I'll have to call on people. So, Dr. Pradeep Lone, तर सांगू शकाल का? आणि अनम्यूट करा. Majority of poisonous snake bite.
Viper, sir, viper.
Okay, thank you. Then moving on to the next one. According to guidelines issued by Government of India, what is the initial recommended dosage of ASV for treatment of poisonous snake bites? Option hota A, dosage varies depending on severity and type of snake bite. Second was 10 vials, third was 5 vials, and fourth was 3 vials. What's the correct response?
10 vials.
Okay, very good. And fourth question was fang marks after bites may be absent in which of the following poisonous snakes? Cobra, Russell's viper, saw-scaled viper, and crate. Other people can also speak. It should not be only a few speaking. Dr. Deepmala Patil, तुम्ही सांगू शकाल? मॅडम अनम्यूट करून बोलाल. Hello?
Sir, I want to repeat the question.
Fang marks after bites may be absent in which of the following poisonous snakes? Cobra, Russell's viper, saw-scaled viper, and crate. Fang marks नसू शकतात.
Saw-scaled viper.
सी तुमचं saw-scaled viper म्हणतात का तुम्ही?
Yes, sir.
अच्छा, दुसरं कुठलं आन्सर आहे? मी कव्हर केलं होतं, सरांनी कव्हर केलं होतं, भास्कर सरांनी कव्हर केलं होतं. कोणी दुसरं उत्तर देऊ शकेल प्लीज? डॉक्टर प्रदीप लोणे.
Crate, sir, crate.
क्रेट, बरोबर. नंतर पाचवा प्रश्न आहे, there is some risk of anaphylaxis with anti-snake venom. This risk of anaphylaxis can be reduced by option A आहे giving injection hydrocortisone, option B आहे giving injection adrenaline subcutaneously before ASV, option C आहे giving tablet paracetamol and Avil, and option D आहे giving injection CPM before starting ASV. डॉक्टर अनिता, डॉक्टर दीपमाला पाटील सांगू शकाल? डॉक्टर दीपमाला पाटील अनम्यूट करून सांगू शकाल? किंवा दुसरं कोणाला बोलायचं असेल तर तेही बोलू शकता. दिस जस्ट फॉर रिवायझिंग. जे आता आपण जे प्रश्नांची उत्तर दिली तर लक्षात राहील, नाही तर विसरून जाऊ आपण सगळे.
डॉक्टर अनिता, डॉक्टर अनिता जमगाडे.
बरं, दुसरं कोणी?
सर 1:1000.
Right. So 0.25 ml subcutaneously before starting ASV. Very good. Next question ahe. A 30-year-old female patient is brought to PSC with history of snake bite 1 hour ago. The patient or the family member have not seen the snake. The examination does not show any fang marks, local swelling, bleeding from gums, or signs of paralysis. What else would you do? Option A ka check 20-minute whole blood clotting time. Option B है give 3 vials of ASV. Option C है give 10 vials of ASV, and option D है reassure and send the patient home. याचं काय राहील आन्सर? कोणी देऊ शकतो उत्तर? तुमच्याकडे पेशंट आला आणि हिस्ट्री आहे स्नेक बाईटची, पण काहीच इतर एक्झामिनेशनवर काहीच फाइंडिंग्स नाहीये, तर तुम्ही काही ऍडिशनल काही कराल की ASV द्याल 3 वायल 10 वायल, किंवा रिअश्युअर आणि सेंड द पेशंट होम? Okay, so some people are responding on the chat. So let me see. याच्यात ए ऑप्शन दिलेला आहे डॉक्टर जगदीश पाटील. तर डॉक्टर जगदीश पाटील हे चेक करतील 20-minute होल ब्लड क्लॉटिंग टाइम, तर ते बरोबर आहे. पुढचा आहे, when an adult patient with poisonous snake bite was being treated with ASV, patient develops itching, rash along with nausea and vomiting. Her blood pressure drops to 80/50. You suspect anaphylaxis and stop ASV. Which is the first medicine you will give to treat anaphylaxis? 100 milligram IV hydrocortisone, 0.5 ml IM adrenaline, 10 milligram IV chlorpheniramine maleate, and D, none of the above are needed as ASV drip is stopped. याच्यात काय द्याल? Question 7. B. ठीक है. 0.5 ml IM adrenaline is the right option. Very nice. Okay, 50-year-old male comes with complaints of abdominal pain and generalized weakness after he woke up from sleep at his home in village, which is located in forested area. He is unable to walk well due to weakness. Examination shows SpO2 of 94%, 130/80 blood pressure, pulse 110, bilateral ptosis, and he can only hold his breath for 40 seconds. He has some difficulty lifting his head from bed. There is no history of snake bite, and there are no fang marks. His random blood glucose is 90 milligrams per deciliter, and a 20-minute whole blood clotting test is negative. What will you do? Option A, give him 500 ml RL so that he feels better. Option B, start him on ASV and prepare for intubation. Option C, give him 4 milligram ondansetron IV and observe. Option D, give him 500 ml of 5% dextrose, as he has not taken anything orally since morning. अच्छा, इथे चॅट बॉक्स मध्ये येत आहेत, तर आन्सर्स येत आहेत प्रिडॉमिनेटली बी आणि गिव्ह ASV. सो व्हेरी राईट. सरांनी ही केस डिस्क्राईब केली की क्रेट बाईटच्या केसमध्ये देअर मे नॉट बी एनी हिस्ट्री ऑफ स्नेक बाईट ॲज सच, अँड पेशंट विल प्रेझेंट विथ न्यूरोपॅरालिसिस. सो व्हेरी नाईस. So next is we have a 45-year-old female patient comes with complaints of unknown bite on her left foot while she was working in her paddy farm for about 1 hour ago. Examination shows normal SpO2, BP 150/90, pulse 112. She has fang marks on her left foot and there is bleeding from those marks. She has pain and swelling up to lower 1/3 of her left leg, and whole blood clotting time is 20 minutes is positive. What will you do? Option A, wait for 1 hour to see if swelling increases. Start her on ASV. Start her on ASV and repeat 20-minute whole blood clotting time after 6 hours. Start her on ASV and repeat for 20-minute whole blood clotting time after 1 hour.
Shardul Deshmukh, can you answer? Shardul Deshmukh, please unmute yourself. Yeah, answer it.
Sir, give ASV and 20-minute whole blood count after 6 hours.
Very nice. So this was a double याच्यात दोन प्रश्न होते याच्यात ऍक्च्युअली की एएसवी द्यायचं की नाही आणि दुसरा होता की रिपीट कधी करायचं होल ब्लड क्लॉटिंग टाइम. So it has to be repeated after 6 hours. So very nice. The last question is 9-year-old female child is brought to PSC after snake bite on her right hand 2 hours ago. Her vital parameters are stable. She has fang marks on her right hand and there is bleeding from those marks. She has pain and swelling up to lower 1/3 of right forearm. Her 20-minute whole blood clotting test is positive as blood has not clotted after 20 minutes. She has tight tourniquet on her right mid forearm. What will you do next? Option A, remove the tight tourniquet and start her on 3 vials of ASV as she is a child. Start her on 10 vials of ASV and remove tourniquet slowly after some time. C, start her on 5 vials of ASV as she is a child and remove tourniquet slowly after some time. And last, remove the tourniquet and tell parents that they should not use tight tourniquet in snake bite. Wait for 1 hour to see if patient swelling is improving. B is the right option. So very nice. So with that, we have ended with the questions. Thank you for participating in this question answer session. Sir.
So there are still 2 questions are there, sir. Just please answer. Sir, should I read the questions? The question number 1 is the chronic condition patient with already a low breath count. Then how to discriminate?
तर हा प्रश्न याच्या संदर्भात होता की सिंगल ब्रेथ काउंट आपण करतो पेशंटचं किंवा ब्रेथ होल्डिंग करतो. तर प्रश्न होता की जर का पेशंटला आधीपासून काहीतरी क्रॉनिक कंडिशन असेल जसं अस्थमा किंवा सीओपीडी तर हे डिफरन्शिएट कसं करायचं असा प्रश्न होता. तर तुम्ही म्यूटवर आहात. तर म्यूटवर आहात तुम्ही.
Actually, this is a very rare incident. Patient will rapidly deteriorate in a neuroparalysis such patient. We have to take care of SPO2 and importantly, rather than getting depression, this patient need a intubation or bypass.
Right. तर युजली याच्यात सिंगल ब्रेथ काउंट अफेक्टेड व्हायला लागल्यावर टोसिस युजली असतं सोबत. Will also, that can help you sort of differentiate between other chronic conditions.
Sir, another question was after completing 25 doses of ASV and there is still no improvement, then what to do next?
Think of DIC. Think of DIC. Decimeter interoscoculation or severe platelet deficiency.
आणि जसं म्हणजे क्रेट बाईट मध्ये जर का न्यूरोपॅरालिस असेल तर एनिवे इंट्युबेट होऊन जाईल. इंट्युबेट झाल्यानंतर तुम्ही एएसवी नाही जरी दिलं तरी पेशंट इम्प्रूव्ह होईल स्पॉटेनियस.
If patient are having alcohol, then does the treatment changes? The mode of treatment changes?
That is problem is alcohol mode of treatment doesn't change it because clinical manifestation will be difficult to interpret in alcoholic, but we should go with our clinical manifestation and treat accordingly.
Okay. Sir, anything like the maintenance dose of ASV?
No. There is no maintenance dose of ASV at all.
And one question is that how to give the ASV in case of anaphylaxis?
What?
How to give the ASV in case of anaphylaxis?
I have just discussed detail, na? You just stop the ASV, treat the anaphylaxis, and if doesn't respond, you change the batch of the ASV. Batch of the ASV can be changed.
And then restart. Once the patient is stabilized, restart ASV.
Yes, definitely.
You have to complete.
Problem is this, what I feel, see, hello?
Yeah.
Hundreds of lectures given, the response is very poor. I don't know why. This is a discouraging response for the snake bite treatment.
We'll have to work harder, I guess.
Yes.
सर तुम्ही तर किती वर्ष काम करता आहात तुम्हाला
45 years, last 45 years.
25 वर्ष सर एकच स्नेक बाईटचं आणि मॅनेजमेंट.
सर कदाचित तुम्ही शिकवल्यामुळे खूप लोक ट्रेन झालेले ऑलरेडी.
Even medical institute professor asked me whether prazosin injectable available, how much injection to be given. It's not available.
आणि
What to do?
मेनली टर्शियरी इन्स्टिट्यूट सिटीज मध्ये आहे, तिथे बरेचदा स्नेक बाईटचं एक्सपोजर नसतं. जिथे ज्या रुरल एरियाचे मेडिकल कॉलेज आहेत तिथे जास्ती असतं, पण
Yeah, correct.
त्यांनाही राईट इन्फॉर्मेशन नसते. तर दिस इज इम्पॉर्टंट.
When the patient goes to the tertiary care, no need to give ASV. Already that venom has already acted.
Exactly. एक प्रश्न आहे. आणि त्याच्या आधीचा होता एक प्रश्न थोडा 24 तासांनी आफ्टर 24 hours of poisonous snake with received 25 dose. What is Dr. Prachi? Can you elaborate on this? Dr. Prachi Shirbhate? काय प्रश्न काय आहे पूर्ण नीट समजत नाहीये.
Plus unmute yourself. Dr. Prachi. Can you hear us? Are you still there?
अच्छा ठीक. तर माझं अंदाज आहे की 25 फायल्स मिळाले आणि 24 तास होऊन गेलेला आहे, तरी द्यायचं काय ASV ऍडिशनल हा प्रश्न राहतो. भास्कर सर त्याच्यावर.
No additional. One thing you should remember, if the patient of viper bite doesn't receive a ASV and he come too late after 2 to 3 weeks with a bleeding disorder, you have to give ASV. You are never late to give ASV to the viper bite because the molecular size of viper is big, very big size.
Sir, is there any treatment protocol in case of green pit viper bite cases?
Which viper?
Green pit viper, sir.
Green pit viper.
No, we don't have protocol. But the problem is just taking paraspecific action of the venom. That we can give a polyvalent. But pit viper rarely cause renal failure. We have to observe the patient.
Okay.
Just a read, read scientist. We received the viper bite. There was no antivenom. Ekis bite. He observed for 6 weeks and get cured.
Sir, okay, sir, there is one interesting question. Patient is in coma. A reason not detected. Can we give the ASV considering it is a snake bite?
No, unless until proved. Don't. Yes, we will kill him because you will have to coma. If you keep the palm on the side, and if there is slight movement, then it's snake bite. How the pupils is there? History is very important. Taking history is very important. First, you give the glucose first. Patient may have hypoglycemia.
Okay. Any questions? We are still last 5 minutes. If anybody has any question in his mind, either unmute yourself and ask the questions or write on the chat box so we can answer.
Sir, hello,
PPT
sir.
has been already uploaded.
Hello, sir.
Yeah.
Sir, please describe about the murmur felt at the ptosis site. What sir has described? Some orbicularis oculi, upper orbicularis oculi has a murmur feel. Bhavskar sir has explained it.
सर तुमच्यासाठी प्रश्न आहे. भास्कर सर तुमच्यासाठी प्रश्न आहे. तुम्ही मर्मर डिस्क्राइब केली होती ऑर्बिक्युलरिस ऑक्युला त्याच्या संदर्भात.
No. That is a cold. This is a cold therapy. Yeah. You see ptosis. Yeah, because rapid acting neostigmine is not available. Riscolin is not available. So whether to differ is a very nicely bedside test, which is used for myasthenia gravis. You can put this hypothermic ice back over the totical eye, and because of hypothermia, sensitize the receptor to existent acetylcholine. Suppose the patient is respond, then you can give neostigmine.
What should be preferred fluid with ASV?
Except
कुठल्या फ्लुइड मध्ये द्यायचं ASV असा प्रश्न.
Normal saline.
नसेल नॉर्मल saline काय द्यायचं?
डेक्स्ट्रो आपल्या रुटीन डिस्टिल वॉटर मध्ये आहे ना मग. पण नेव्हर गिव्ह इन डेक्स्ट्रोज. Dextrose is injurious to the health.
Sir, ringer lactate will be preferred. Ringer lactate.
Yes, you can give ringer lactate. There is no harm.
Sir, what is about NBM status of the patient while snake bite, after snake bite?
NBM स्टेटस आणि स्नेक बाईट ट्रीटमेंटचा काही संबंध आहे का?
काही संबंध नाही. राईस ट्यूब कडून फिडिंग करायचं. इंट्युबेशन करायला असतं, ते ऍस्पिरेट करत नसतो, त्याला राईस ट्यूब करायचं, राईस ट्यूब फिडिंग. आय सेड ना न्यूट्रिशन ऑक्सिजन इलेक्ट्रॉन बॅलन्स.
एक प्रश्न आहे की व्हॉट एक्झॅक्टली इज द यूज ऑफ 20 minutes whole blood clotting time?
What?
20-minute whole blood clotting time चा काय यूज आहे मेनली अच्छा अच्छा can we link with
सर क्वेश्चन हॅलो सर
हा हा
क्वेश्चन असं आहे की
हा सांगाल ना
आपण जे प्रोटोकॉल मध्ये पाहतो की सिस्टमिक एन्व्हायरमेंट जेव्हा आपण ASV द्यायचा आहे सो
Right.
इफ इट इज व्हस्क्युलोटॉक्सिक स्नेक बाईट त्याच्यामध्ये आपण 20 मिनिट्स क्लॉटिंग टाइम पाहायचा आणि मग द्यायचंय पण सरांनी जसं सांगितलं की यू डोंट वेट फॉर 20 मिनिट्स क्लॉटिंग टाइम
जर का
आणि जर
local feeling आहे.
बाईटची हिस्ट्री आहे तिथे एडिमा आहे तर यू स्टार्ट ASV यू
Exactly.
डोंट वेट फॉर 20 मिनिट्स
Exactly.
मग आपण गाईडलाईन मध्ये तसं धरायचंय की क्लिअर कट हिस्ट्री असेल आणि इडिमा आहे तर आपण द्यायचंय ऑर वी
Right.
वेट फॉर दॅट किंवा ते फक्त आपण जेव्हा मॉनिटर करणार 6 तासांनी तेव्हा वापरायचंय
नाही होल ब्लड क्लॉटिंग टाइम घेऊन तुम्ही लोकल स्वेलिंग इंडिकेट्स लोकल सिंड्रोम वेअर देयर इज एन्व्हेनमेशन आणि होल ब्लड क्लॉटिंग टाइम हे पॉझिटिव्ह असेल तर तुम्हाला ते मॉनिटर करायला लागेल ASV साठी मॉनिटर करायला तुम्हाला ते लागेल
म्हणजे आफ्टर 6 आवर्स आपल्याला पुन्हा रिपीट
Yes,
करायचं त्याच्यासाठी
Right.
Okay.
सरांचं कॉमेंट आहे की
20 minute whole blood clotting test is readministration for yes. Is
ओके
readmission, and that should be interpreted as a blood clotted or not clotted.
Exactly.
पॉझिटिव्ह
Okay.
निगेटिव्ह बोलायचं नसतं सगळ्यात आपलं बी कन्फ्युजन ऐकणाऱ्याचं कमी ब्लड क्लॉटेड
बरोबर आहे
आणि
Yes,
ती
sir.
प्लॅस्टिक ट्यूब नको
ओके सर ओके थँक्यू सर थँक्यू
Sir, we used to give Maxal dressing for local swelling. So are we supposed to give it right now or not give?
वी हॅव टू गिव्ह नो प्रॉब्लेम
मॅक्सल ड्रेसिंग ठीक आहे फारसा आहे त्याचा म्हणजे यूज असं नाही आहे पण तुम्ही वापरत असाल तर काय
Whether it is empirical or what?
मॅक्सल एम्पेरिकल आहे ते बरेच वेळा काही ट्रीटमेंट फिजिशियनलाच बरं वाटतं तर तशातली ते
Sir, and you had explained about calcium gluconate. Exactly, म्हणजे when to give this calcium gluconate?
6 hourly to be given, it enhances the neuromuscular conduction. Because of
कुठल्या सांगायला
in
लागेल कुठल्या
neuromuscular blocking,
Right.
there is absence of neuromuscular conduction. Calcium channel plays the important role for depolarization and repolarization and neuromuscular conduction. The calcium gluconate can be given 6 hourly till the patient recovers.
Hello,
हा
sir.
Sir, can you tell the dose of calcium gluconate?
6 hourly, this 10 ml, 10 cc vial, 6 hourly.
Hello,
Okay, sir.
हा, बोला
Thank you.
बोला
sir.
हा
वायपर बाईटच्या केसेस मध्ये कधी कधी सिव्हिअर पेन असतं तर त्या
But-
पेनसाठी डायक्लोफेनेक किंवा काही वापरायचं का म्हणजे समजा एनसीएट्स वापरायचे का सिव्हिअर पेन इन अपडामिन म्हणजे ASV दिलं तरी खूप पेन असतं
use of NSAID in case of severe pain of process hyper.
You see, I have seen a death due to NSAID. Diclofenac injectable, I have seen a death and anaphylaxis. Now the problem, patient is very anxious. He has already tolerated looking at the snake bite and he will tolerate that pain. No sooner you complete the ASV, patient pain will reduce, edema will reduce. You can treat with good antibiotic or cameral port, that reduction of edema, pain will go. But pain is important transit in cobra bite. But you see, when the cobra bite occurs to the patient psychology totally changes. This bother about the pain. He was bothered about the treatment now.
पण प्लेन
Then it's
पॅरासिटामॉल तुम्हाला द्यायचं आहे तर देऊ शकता
Yeah, you can give acetaminophen, but NSAID to be avoided because kidney
Yeah.
failure is very common.
एक्झॅक्ट
Sir, another question is that rapidly developing swelling, meaning that what is the time frame here? In a time frame, duration and rapidly developing swelling.
That actually they say that as per the length of the snake, the swelling will be according to the length of a snake.
I think त्याच्याशी ट्रीटमेंट इट इज रिलेटेड टू ट्रीटमेंट सो विदिन हाफ एन आवर इट हॅज लाईक ऑलरेडी डबल्ड
Yes, then rapid.
subjective guideline which is mentioned that rapidly developing swelling you should start ASV. But any swelling, I mean, in that case, any swelling that you see which is increasing, you should give ASV.
This indicates the venom is more spreading. Muscle is spreading very fast.
Sir, my interesting question is here, sir. If adrenaline is not available, shall we give the ASV or refer the patient, or can we use the expired adrenaline?
Don't give expired adrenaline.
No. आणि ऍड्रेनालिन फोडलेलं वांपूल ठेवायचं कन्झ्युमर प्रोटेक्शन साठी. आणि मुद्दा असा आहे, ज्या दिवशी PSC, the day on which PSC procure the ASV, first they should procure the adrenaline, then the ASV.
आणि नसेल ऍड्रेनालिन तर तुम्ही एएसवी तसंही देऊ शकता. पूर्वी आम्ही द्यायचो नाही, एएसवी तसंच द्यायचो. सो स्टार्ट एएसवी. डोंट इफ यू डोंट हॅव ऍड्रेनालिन यू कॅन स्टिल स्टार्ट.
लो पोझिशन then सगळं आपल्याला त्यावर मेफेंटिन द्यायचो आपण.
राईट.
मेफेंटिन.
राईट.
Yes.
Sir,
काय-
will
hello?
it BT of CT is sufficient
The important thing, why?
rather than
You see,
that 20 WBCT?
even
Only
steroids
BT.
are very important.
Yeah.
Steroid enhances the adrenaline potentiality. So if you give steroid of adrenaline, steroid enhances the potency of the adrenaline.
सर प्रश्न आहे की बीटीसीटी सफिशियंट आहे का होल ब्लड क्लॉटिंग टाइमच्या ऐवजी?
I never do BTCT. I do 20-minute whole blood clotting test. To be
Yeah.
very frank.
Because 20 whole blood clotting test is more objective.
Whole blood.
And BTCT
Whole blood. It is a whole blood.
Yeah.
Yes.
काही हॅलो
हाँ. Like 10 vials of 400 ml NS over how much time period? 1 hour. So first each dose should be given over 1 hour. So first 10 vials over 1 hour, next 10 vials द्यायचे असेल again over 1 hour, त्याच्या पुढचे 5 द्यायचे असतील तर over 1 hour.
What is the desensitization procedure in case of
No. Now another thing, what we observe during primary health center, what happened? We used to give 10 ampoules of ASV, then bleeding continue. After we wait for half an hour and we repeat this, then bleeding stop. So that is very important. If the bleeding, not the patient to die of bleeding.
Yeah.
So
So in that context, I mentioned in case the next 10 vials is needed, then give it over again 1 hour period.
It is 10-10-5.
10-5 देना है.
6 hours, 6 hours and 6 hours.
But then that
If the bleeding continue, you can repeat in half hour. Bleeding continue. If bleeding continue, we have to stop the bleeding.
Serious bleeding occurs. What is desensitization procedure in case of severe anaphylaxis reaction of ASV? It's a treatment. There is no desensitization, just treatment of anaphylaxis. Adrenaline being the first choice, and we already discussed that you have to give adrenaline and repeat adrenaline. If it doesn't respond, then give hydrocortisone and Avil. It's gradually, slowly increasing localized swelling. By and large, if you find it, if it is increasing, give ASV. If there is no swelling, that's when you have to, watch and observe. If there is zero swelling, sir has shown some nice pictures where you start seeing swelling. The moment you start seeing swelling, you can give ASV.
Sir, anything for anxiety or raised blood pressure after snake bite patient? Which antihypertensive should we use?
Anxiolytic drugs are role.
Anxiolytic. Sir, question is, what is the role of anxiolytic medicines if the patient is very anxious?
Yes, which anxiolytic and for raised BP, what should we
First
use?
important thing is the doctor has created a good competence society that he will recover, he will treat the patient. That is very, very important. You see, when anxiety comes, you can give any sedative, any anxiolytic. There is no problem, provided you are damn sure it's not venomous, not bitten by the venomous snake. Because it's anxiety, patient may show you ptosis, patient may show hypertension. This hypertension is a transit phenomenon.
No need to add the antihypertensive drugs, sir. In that case.
No.
Usually it improves. It's transient. It improves. You don't have to chase that blood pressure and go after it unless patient is having other complications. Usually it settles down. Usually patient is initially will be coming very anxious. If you are confident, you have tell ASV.
You see, around 1986, 83, when I come to prazosin first time of scorpion bite, huge patient used to come to me in my hospital. No soon patient relative come 10 to 20. When I take the patient on my cot, patient suddenly go to sleep. They were so damn sure patient will take morning to the patient at home. So this much to say, they used to sleep, we both used to awake.
Sir, one question is that what can be done if the patient in the comatose condition brought to the PSC, confirm the case of snake bite, intubate or give the ASP first?
No, first thing is that you see, routine comatose patient. Do the blood sugar, do the SpO2, do see the respiration. If there's a intubation, must intubation. Intubation is not essential, it should be cobra bite. Do the intubation, do ambivalent ventilation, maintain oxygenation, maintain electron balance, rise to nutrition, and then transport the patient.
No need to give the ASP first in that case.
No. Yes,
that is last time.
Unless you are damn sure.
First ABC. Correct.
Some
the
book
ABC.
has already mentioned patient was comatose, yes, we can patient woke up. That is wrong. You see what happened? There is a good history regarding crate bite. When there was no crate bite treatment, आणि त्या काळामध्ये इथिओपिया वगैरे मागासलेल्या देशामध्ये ग्रेट वाईट पेशंट झाला की तो 3-3, 4-4 दिवस बेशुद्ध असायचा हो, 5-5 दिवस. तर द रिलेटिव्ह इज टू फील ही डाईड. सो त्याची 3 लाकडाची नाव करायची आणि त्याला समुद्रात सोडून द्यायची. आणि तो दुसऱ्या बाजूला गेला की तो अवेक होऊन जायचा. आणि आफ्टर 10 years they used to meet that. This is a real story mentioned in the snake bite literature. म्हणजे remember, whether you what is indicate, whether you treat or not treat, snake bite will recover.
Okay. Sir, use of ethamsalate or pause for the case of bleeding. Use
What?
of ethamsalate or pause.
No, we are, this tranexamic acid is much better. Fibrinolytic. It is a fibrinolytic.
And any role of vitamin K?
Vitamin no role. No, there is no cause. Liver is normal. Na?
Yeah.
But ASV is the predominant treatment, so you should give ASV.
Yes.
Don't
Yes,
give ASV.
yes, we have no substitute.
Yeah.
Now we should fight for. We must have regional ESV.
Yeah.
We must have monovalent ESV or bivalent ESV. We must have regional ESV. That is important now. Rather, now we are stuck up with ESV, clinical signs, symptom, manifestation. That is over now.
Sir, questions are over from the chat box.
Okay, thank you.
Anybody want to ask the questions? Still, they unmute yourself and ask the questions.
हॅलो सर.
Yeah.
बावस्कर सरांचं प्रेझेंटेशन अपलोड नाही झालेलं फक्त.
बरं, करतो. येस. नाही, दोन्ही आपले रिसर्च पर्सनचे प्रेझेंटेशन त्यांच्या परवानगीने मी अपलोड करतोय.
सरांचं झालंय.
Yeah.
Thank you, sir. Thank you. Very nice.
The people are asking your phone number, sir. So should we share?
Yes, why not?
Yeah.
9422
9422
594
594
794
794.
Yes. Never discharge and never switch off. So we get many phone numbers.
Yeah. I have written the sir number in the chat box. Anybody can get obtained
Yes,
from
given permission to call in it.
Yeah.
Yes. But they feed me properly. That is important.
Yeah.
Feeding is
You have
proper.
to invite
That
sir.
is important. नहीं तो क्या सांप को देखा है, उसका बाइट हुआ है, वो भी ऐसा है, ऐसा कर रहा है. That is not meaning.
If you
They
call
should
sir,
well
sir will ask 10 questions about
Huh?
this webinar. And if you answer correctly, then he will ask you.
Yes. Now there is good chapter I have written in. Now that book is going to publish.
Yeah.
Annals of textbook of Annals of Neurology, Indian and Neurology.
Okay. Sir, there are still 2 questions are there. Snake bite, snake poison only flow in the lymphatic is right?
So initially the absorption is through lymphatic. Later on, once it's in systemic circulation, then it's everywhere.
Unless the snake is inject the venom in the vein.
Directly.
आणलंय ना, 2 आणले होते.
What should be the infusion rate of it? It's again to be given over 1 hour. So the simple rule you need to remember is, usually in adult drip rate is 16 drops is equal to 1 ml, 16 to 20, which varies with the provider. So 500 divided by 60, you do the calculation and then you calculate 16 drops. So it comes about 130 to 160 drops per minute.
Okay, I think the questions are over. I thank Dr. Bavaskar sir first for his amazing lecture and a very friendly attitude to answer the questions and to get in touch with each other. Thank you very much, sir. I also thank Park Foundation. I also thank Dr. Yogeshwar Kalkonde sir. I also thank all the medical officers who have joined this webinar, and henceforth also we will conduct such webinars, interactive webinars. May this is a good thing that sir.
Yes, I want to students are there or gone?
They are there, sir.
Yeah.
So what is the research? I will tell them two sentences only.
Yeah.
What research? You see, when I am doing a scorpion bite, there was one patient developed Brugada syndrome due to scorpion bite. That Brugada syndrome and disappeared. So I studied in detail. This scorpion venom caused sodium neuronal channel activator. So ultimately I published in Lancet, why not use the sodium channel activator molecule to reverse the Brugada syndrome? That is the research. Next, now in the crate bite, you see, now the rabies, we don't have action, the treatment of rabies. Rabies means 100%. Now the rabies virus outermost is a glycoprotein. Now glycoprotein cause upgraded of the upgradation of the cell in the neurons, and they will cause more and more mature, more and more mature cell, rabies vaccine, rabies virus. Now beta bungrotoxin of the great venom structure is mimic the beta glycoprotein of the rabies. So we can prepare antibodies against the rabies by the glycoprotein, or we can use the create antivenom as a treatment of rabies, which I published in some big journal.
Thank you, sir.
Good. Thank you.
Yes,
Sir,
yes.
sir, I received just very nice comment. I will got a comment of the day that one of the audience wrote on the chat box that I ever for the first time added any Padma Shri person phone number in my phone book.
I don't know. That is
Yeah. So with this comment, I thank Dr. Bhavishkar sir.
No, you see, I just forget Padma Shri. When you say Padma Shri, then I recollect I am Padma Shri.
Yes.
I just forget Padma Shri. What is it? Huh?
Sir, with your comment and good gesture, I thank you once again. I thank Dr. Yogeshwar sir. I thank
Yes.
PAP and all medical officers. And I declare hereby that our today's webinar is over. Thank you very much.
Thank you.
Thank you.
Thank you. Medical officer होतो. ते पास मध्ये आपला. जसं अमेरिकन आला. काही पण जो होता ना. हा. कोणतं तिथे दुसरा इकडे. आणि ते राजेश जाऊ शकत त्याला आपल्याला जाऊ जेनेटिक काम करत होता. हा नाही तो येतो नाही तो आता याला खेड्यामध्ये काम करतो शिकायचं रायपूरला. एक तो होता लेक्चर आणि तो दुसरा आयसीएम